Video. Good morning and welcome to the Edward B. Dietrich Vascular Surgical Society Vascular Conference for 2023, our 6th annual Endovascular Conference for Africa and Rural America. I'm glad you're here today and we thank you for attending yesterday. We'd like to move things along quickly today. We hope yesterday's conference was educative for the attendees, and we hope that you'll stay on today until the end if you can. We have some great speakers today, and we look forward to their talks. First speaker today is no other than Dr. Geoffery Cousins, who is a cardiac surgeon here in Parkersburg, West Virginia. He's a consultant in the cardiac surgery and has vast experience doing open heart surgeries and minimally invasive open heart surgeries. We thank him for the opportunity to speak today and look forward to his talk. And also, please look into the CME information. Dr. Gupta will give you that information right now, and Dr. Cousins will start his talk. Thank you, Dr. Cousins.
Hi, good morning. Thank you everyone again for coming. Just before we begin, I just want to say that the coordinators of this program have nothing to disclose, and neither do the presenters. For the continuing medical education credits, a survey will be coming to your email, a post-conference survey. So as soon as you fill that out, you guys will get the CME certificate. So if you haven't already emailed me or given me your email, please put it in the chat anytime during the presentation, and I will forward it to the education department. And Dr. Cousins, we are ready for you. Thank you.
Trying to share my screen.
Is it letting you share it now?
It is not.
I just stopped sharing, so do you want to try once more? It's right at the bottom in green. Yep, perfect.
That's it.
Thank you.
Okay, now I need to be able to play. Okay, can you see my screen there?
Yeah.
Yes, sir.
Okay, good morning. It's great to be here with you today. I'd first like to say thank you and congratulations to Dr. Oye and the team for convening the 6th Annual Global Endovascular Conference for Rural America and Africa. This is very important work that you are doing, and we are very appreciative. As you know, I'm from Southern West Virginia, and it doesn't get much more rural than that. My talk today is about revisiting off-pump coronary revascularization. We've talked about this before, but over the past several years or so, there's been some negativity about off-pump coronary artery bypass grafting. And there's even been some suggestions from several prominent surgeons that it should be abandoned. However, there are some large multi-center trials that we'll look at that have confirmed that off-pump CABG is at least as safe and durable as on-pump CABG when performed by experienced surgeons. And additionally, there have been several large studies that have shown that off-pump CABG reduces the stroke, MI, renal failure, and death. And this is especially so in higher risk patients, and particularly when combined with what we call a no-touch or an aortic technique, which we'll talk about a little bit more. Now, as many of you know, I'm from Southern West Virginia, but I've been all over the country in search of state-of-the-art heart surgery procedures to provide high-quality care here in West Virginia. Because as you know, cardiovascular disease is the leading cause of death in the United States and most developed countries, and West Virginia is overrepresented with cardiovascular disease, as you all know. The majority of the deaths with the cardiovascular disease are indeed due to coronary artery disease. Coronary artery bypass grafting is the most common heart surgery that's performed worldwide, and it can be traced back to more than 100 years. Now, depending on what you read, that said, most of the literature says there's about 340,000 CABG that are performed each year in the United States. And since 1997, there have been more than about 2 million off-pump CABG procedures. And so if you take a look at the heart and the coronary arteries, the picture on the left shows the basic picture that we typically see when we see pictures of the heart. But if you look at the picture on the right, they've taken away all of the substance and left just the vessels. You can see the ascending aorta, the root of the aorta, then part of the ascending aorta. And as soon as the aorta comes out of the heart, it gives the right coronary artery, which provides blood to the right atrium, the right ventricle, as well as the portion of the left ventricle and the back of the septum. And on the other side, you have what's called the left main, and they call it the main because it gives one down the front, the LAD, which supplies blood to the front and bottom of the left ventricle, as well as the anterior portion of the septum. And then you have the circumflex artery, which supplies blood to the left atrium and the side and back of the left ventricle. And indeed, when we're talking about coronary artery disease, we're typically talking about these arteries. And over time, because of our diet, stress, diabetes, high blood pressure, tobacco use, and what have you, these arteries develop cholesterol buildup, which narrows the arteries and prevents adequate blood supply, and then you get ischemia, just as you do in peripheral artery disease. Now, CABG goes back a long ways. Way back in the 1800s, there were some surgeries that had begun to be performed, but prior to this time, people were pretty gun-shy about opening the chest. But back in 1893, Dr. Daniel Hale Williams intervened on a patient who had a stab wound to the chest, and he repaired rent in the ventricle as well as the pericardium. And then in 1896, Wren and Farina did a similar procedure. Now, it wasn't until 1930s that John Gibbon developed a workable pump or oxygenator, or what we call a heart-lung machine. And he used that in 1953 to perform a atrial septal defect closure using total cardiopulmonary bypass. In 1945, Arthur Weinberg actually implanted the lima directly into the myocardium, developed what was called the Weinberg procedure. And CABG indeed has become one of the greatest surgical achievements of the 20th century. This is just a picture of Gibbons there with one of his original heart-lung machines. I'm glad that they got a lot smaller than that nowadays. And this is Dr. V.I. Kolosov, who was a Soviet Union physician who back in 1967 had 12 patients where he performed a lima to the LAD via left anterior thoracotomy, and 11 of these patients actually survived. And this was probably one of the very first beating heart surgeries because at that time they were not using the heart-lung machine. Later at the Cleveland Clinic, Dr. Rene Favalero back in '67 devised a technique of using a saphenous vein graft for coronary bypass. And he, along with Dr. Mason Soames, the father of coronary angiography, went through and did quite a few of these patients with the saphenous vein. And Soames gave us what was called the sonography or the coronary angiography. And what you can see here is dye is being injected into the ascending aorta, into the left main here. And you can see the LAD coming down the front, the circumflex around the back here, and then the right coronary artery. So this is our roadmap that we typically use. And if a patient has developed chest pain, ends up getting a stress test, which is positive, they then go for coronary angiography, or sometimes nowadays CT angio. But even if the CT angio is positive, we still send them for coronary angiography. And once it's been found that they are not a candidate for a percutaneous or endovascular procedure, that's when we come into play. And contrary to what people say, the best way to a person's heart is still through a midline sternotomy. This is something that is concerning for patients as well as some physicians who are referring patients. But the median or the midline sternotomy is very well tolerated by greater than 99% of the patients. Patients are often concerned about post-op pain, but what we find is that most patients don't have any significant pain. And many of my patients come back to the office at 30 days after being sent home with about 30 pain pills, and they'll often comment and they'll say, "Doc, I didn't take any pain pills since I left the hospital." And as you'll see with looking at our data later, deep sternal wound infection is almost non-existent nowadays. And so people are concerned that we're going to crack their chest or break their chest, but we make a very controlled incision. We use a saw to make a very controlled cut in the sternum. We then have access to the pericardium, which we open, and then the heart is available there. At this point, then we make a decision regarding these bypass grafts as to whether or not we're going to do the CABG using cardiopulmonary bypass or on pump, or whether we're going to do it with the heart beating. Now, if we're going to go on pump, then we have to put cannula in the ascending aorta as well as the right atrium. And we'll talk a little more about that in a minute. And one of the big concerns about using a pump is post-perfusion syndrome or memory loss, or what is commonly called pump head. And we'll talk a little more about that as well. But the big issue, of course, is stroke, as well as renal failure, lung failure, and bleeding, because this pump is pretty big. All of the surfaces are plastic coated, and the blood has to see those surfaces. We have to give a large dose of heparin to keep the blood thinned out and keep it from clotting during this time. And so there's significant issues sometimes with bleeding in relation to the heart-lung machine. And then there's a systemic inflammatory response that takes place when the blood products see the foreign materials related to the pump. And this is just another schematic. If you look on the left here, you can see it gets quite complicated. There's lots of cannulas in the ascending aorta. There's cannulas in the right ventricle. There's another cannula in the ascending aorta here. And you can see those things here, the aortic cannula, the cross clamp, which we'll talk about, the root vent here, and of course, the venous drainage cannula that's placed there. So all those things are pretty invasive. Or we can do it with the heart beating and use primarily these two devices here, which down on the bottom right, you see a suction cup, which you'll see is placed on the apex of the heart. And that allows us to position the heart for access to any of the coronaries that we want to work on. And then once we get it in the correct position, we can put the stabilizer here, which keeps that area of the heart relatively still in relation to the other parts of the heart. So off pump or beating heart CABG, only about 8 to 15% of CABGs are performed off pump. And I actually think that number may be less nowadays than when this literature was put out. It's a less invasive procedure because, as we mentioned, we don't have to do the aortic or the right atrial cannulas. There's less systemic heparin, so there's less blood transfusions. We talked about stroke, renal failure. Also, there seems to be a reduction in the rate of postoperative atrial fibrillation. All these things then lead to a decreased length of stay, cost. And what we found is that traditionally women have not done as well with cardiopulmonary bypass, but when we do their procedure with the heart beating, it seems to equalize the playing field for women. And we get better outcomes for women in high-risk patients, particularly those with a calcified aorta, renal disease, cerebral vascular disease, as well as lung disease and bleeding disorders. So here you see the suction cup on the apex. It looks like we positioned here to do a high obtuse marginal artery, and we place this stabilizer there. The rest of the heart, it continues to, the entire heart continues to beat, but the area in the stabilizer here is a little less active, and we're able to make the anastomosis. And this is a blow up of the area. We place a paroxysmal tourniquet before we open the vessel so that we don't have any significant bleeding from the vessel. And then as far as the saphenous vein graft, this is a picture from many years ago where we used to kind of just fillet the leg open to take the saphenous vein out. But this was fraught with problems, particularly below the knee. And a diabetic, we would get non-healing saphenectomy sites, which could be a big problem. And we used to find ourselves doing what's called Unaboot clinics, where we would place calamine-soaked bandages on these legs to try to dry them out and get them to heal up. But it was a big problem. So now we move to an endoscopic conduit harvest for the greater saphenous and also for the radial artery. And this is the incision that we make now versus the filleting of the leg, as you saw in the previous picture. And then we can use a scope to dissect cephalid and caudate, and then we can take the vein out through a small stab incision, and we get a very nice result. Now here is the ascending aorta. So here's the vein graft here, and we're ready to attach it to the aorta. And here's where you can run into some significant problems with stroke, particularly if you see this aorta here, we put a big metal clamp, a partial clamp on it. Now we're making an indentation with the pickup. And instead of doing that, we move to this type of procedure, what's called a heartstring, where we have a smaller punch. We then insert this little umbrella device into the hole that keeps us from bleeding during the time of the anastomosis. And this prevents us from needing to use the partial clamp, and it has reduced stroke significantly. We always check our anastomosis. This is a flow probe here. And before leaving the operating room, we always check the bypass conduits to make sure that there's adequate flow. We want a pulsatility index less than 5 and a flow of greater than 20 mLs per minute before we're satisfied with the bypass conduit. And so CABG outcomes overall are pretty good. Mortality is low, stroke is improved, as well as renal failure, medial stenosis. And these are CABG outcomes in general. We're going to show you our specific data here in just a second. But this is one paper here that talks about equivalent patency between off-pump CABG procedures. And it's been shown in several clinical series that the patency of the off-pump grafts is as good or equivalent to on-pump. Reduced transfusion rates, we talked about that a little bit. This one also shows a shortened length of stay. The postoperative stroke rate has been reduced. Here you see the on-pump in blue, and then the gold bars are the off-pump. So there's significantly less stroke. We also have transcranial Dopplers that we use. And when we, during the surgery, you get what's called HITS, high-intensity transcranial Doppler signals. And you see that for on-pump, they're significantly higher than for off-pump. And this ends up potentially translating into reduced cognitive impairment that you see with the on-pump surgeries that are performed. Reduced mortality, we talked about, reduced hospital costs. And our current overall STS rating is a 3-star. And this is our specific data. 3-star is as good as it gets. The STS represents 7,600 surgeons worldwide, and the star rating system is the most sophisticated and highly regarded overall measure of quality in healthcare, rating benchmarks in CT surgery in the US and Canada. And only 6 to 10% of the participants will receive a 3-star rating for isolated CABG surgery. So that places us among the elite for CABG surgery in the US and Canada. And there's 4 domains that are looked at: absence of morbidity, absence of mortality, use of the internal mammary artery, and medications. And if you look here, you'll see overall we have a 3-star rating. And if you look, you'll see that even though where we dropped to a 2-star, we're still very competitive at a 97.9% rate. So we're very, the data is very strict, and we're under a very stiff competition. The absence of morbidity, we had 1 patient back in November that was a prolonged ventilator patient. He'd had pneumonia preoperatively. As far as deep sternal wound infection, you see for us is non-existence. The red line shows our like group, and you can see where they stand in relation to us. Postoperative renal failure, again, we have a 0% rate versus our like group, up at 1.1 per 2. When you look at surgical re-exploration, fortunately, we've had none. Use of the internal mammary artery, we use it about 100% of the time, unless the patient's had a radiated chest or some other problem with the mammary. Medications, these includes aspirin, statin, beta blockers, and ACE inhibitor if the EF is less than 30%, and we're 100% with our medications. Other outcome metrics include in-hospital mortality. We had 1 death back in October of 2022. A couple patients had pneumonia postoperatively. And we've struggled a little bit with readmissions because anything that happens within 30 days is related based on STS to surgery, even if some of these patients have come back with GI bleeds, renal stones, atrial fibrillation, or things that may not necessarily relate to us. The length of stay, as you can see, we're on par or better for the total length of stay. And for post-procedure days, we actually do quite well. A lot of our patients get out of the hospital in 3 days. Other process metrics that we are scrutinized about include antibiotic selection, which we are good on selection, the timing, and also the stopping of the antibiotics. We do very well. Postoperative blood products, as you see, compared to our like group, we use a lot less blood products. Ventilator hours, there's that 1 patient who continues to haunt me back from November of 2022. You see our ICU hours, we're down at the range of about 20 versus our like group has ICU hours up around 70. And so this is huge in terms of cost and time of stay. And we had a couple of patients that were readmitted to the ICU after being downgraded. We typically refer 100% of our patients for cardiac rehab. We had 1 patient who fell out back in May of 2023. So, I've been doing this beating heart surgery now for 20 years. I think it's a very durable procedure. I'm very happy that we have STS data now to support that, despite the naysayers, and we will continue to forge on. Thank you very much. I'm open to any questions that you may have.
Thank you, Dr. Cousins. Appreciate the nice talk. As always, a pleasure to hear you talk on this matter. Again, any questions from the audience or from the virtual audience too? What's the cost ramification for up-pump versus on-pump surgery? Are they identical or different?
It's significantly less. Not using a heart-lung machine saves a significant amount of money on its own when we keep the heart beating. Additionally, about 92% of my patients are extubated in the operating room. And so that decreases costs significantly because they don't typically go up on pressors, levo, epi, dopamine, and things along that line. They may go up on an insulin drip or Precedex for comfort. But these patients are typically up in a chair within 4 or 5 hours after surgery. Oftentimes they can be downgraded from ICU to step down status within the first 8 to 9 hours. So that changes the cost significantly. And then quite a few of them are going home nowadays in 3 days after the surgery. So there's shorter ICU stays, shorter hospital stays, and shorter overall costs, which significantly reduces the cost. That's why I think this is important in rural America and also could potentially be duplicated in African countries and other countries around the world.
That was exactly my next question. You just answered it for me. Essentially, with the countries in Africa are now developing Western type diseases such as cardiac problems. The need for open heart surgery is definitely increased. The question is whether or not the cardiac surgeons there can or will adapt this option to improve the services or care for their patients. Yeah. Any other questions? Okay. Well, Dr. Cos, it's been a pleasure. We hope to see you next year or on our Global Ground Rounds. We have the Global Ground Rounds here in Beckley every 3 months. The next one's scheduled for December probably, and thereafter every 3 months. So thank you again once again. We appreciate you helping us out with this on very short notice also. Thank you so much.
Thank you and your team for all that you do. Have a great rest of your conference. Thank you.
Thank you. All right.
Dr. Cousins, you have to just stop sharing your screen. Thank you.
All right, we'll continue with our next speaker, who's coming to us from the UK. Dr. Kumar Das is a consultant endovascular surgeon in the UK. He's director of the program there and continues to work doing complex endovascular surgeries there. He is also affiliated with the Arizona Heart Institute via Dr. Edward B. Dietrich. It's always a pleasure to have Dr. Das come on to give us some insights on vascular related topics. Today, he has a couple of talks he will share with us, and we'll look forward to hearing his presentations. Thank you, Dr. Das.
Thank you, Dr. Oye, and the organizers. Give me a second, I'll be with you.
No worries.
Can you see my screen?
Yes.
Sir.
And you can hear me?
Yep,
That's correct.
perfectly.
Okay. All right, good morning, I should say, from London. And Dr. Oye and the organizers, thank you very much for giving me this invitation to talk at your meeting about some of our experiences here in London. So, shall I start or do you want me to wait?
You can start.
Okay, thank you.
Thank
So, the first talk that I will share with you is about something unusual for surgeons talking about medical management of abdominal aortic aneurysm. But I think that this is the best platform to share this message with all our colleagues. So the talk I'm going to give you today, the first talk is about medical management of abdominal aortic aneurysms. So this is largely based on many experimental works and some patient cohort studies that has been done over the years. And but two particular medicines which have shown promising results with regard to the control of abdominal aortic aneurysms, and that is what I'm going to present to you. Not those animal experimental studies or those cohort studies, but the results of large reviews, systematic reviews, and meta-analysis. So let's see what we are talking about. In this slide, can you see my slide, please? So what I'm trying to show you is the difference between atherosclerotic disease causing constrictive disease in the arteries and those which are dilating disease, which as we call them, aneurysmal disease. There is some pathological differences between there are pathological differences that between the two diseases that we know very well. And as you can see in my presentation, that this is the aneurysmal disease, where most of the disease is mostly involving the extracellular matrix and involving the media as well. And whereas atheroma, where there is deposition of atheroma in the intima and with the fibrous plaque rupture and thrombosis on the plaque. So in order to medically manage these two problems, we have to think differently. And in doing so, we have to look at the pathological basis of aneurysmal disease. So this is what it is, the pathology of aneurysmal disease. Now, what we see in the aneurysm histology is, apart from the genetic predisposition and biological factors which makes us susceptible to develop aneurysm, in the aneurysm itself, in the histology, there are a lot of pro-inflammatory cytokines in the aneurysmal segments. There is matrix metalloproteinase, which are abundant in this tissue, which causes destruction of the elastin and collagen. And also, if you look at that, there is quite a lot of activation of inflammatory cells in this histology of the aneurysmal tissue. And these pathological mechanisms which are responsible for the aneurysmal development have been taken into consideration in the development, in the drug development. So here I'm showing you how different pathological processes which are responsible for the development of aneurysm have been taken into account in drug designing. Here in the first here, the anti-inflammatory effect drugs that has got the anti-inflammatory effect have been considered for the control of the aneurysm. And in that category, you will see metformin is something which is an anti-diabetic drug, which has got the anti-aneurysmal effect. Similarly, statins also has got anti-inflammatory effect. If you look at the inhibition of matrix metalloproteinases, in that sense, we have got statins and various other medicines, some of which, like tetracyclines as an antibiotic, is also known to have inhibition of proteases. Furthermore, here, antioxidative effect, again, in that category, we have the vitamins, statins that are included in the reduction of oxidative effect, which is responsible for the aneurysmal development. And finally, in the synthesis of extracellular matrix, which is again important in the development or stability of the aortic wall, in which case statin is an agent which is responsible for the synthesis of the extracellular matrix. And as you can see in this slide, statins has got almost all the qualities or the virtue which can control the growth of aneurysms. And in my presentation today, I will dwell upon two drug agents. One is the anti-diabetic medication metformin, and the second is the statins. Let's look at what are the evidence available with the use of metformin, the anti-diabetic medications. So in this study, it's a retrospective cohort study. They looked at the results of 14,000 diabetic patients who had abdominal aortic aneurysms and who were also treated with metformin. And they found that there is those who were on metformin, the aneurysm growth rate was reduced by nearly 23%. In another study, which comprised of 8 studies, reviews, and that included over 30,000 patients, and metformin prescription could significantly reduce the enlargement of the aortic aneurysms. And if you look at further results, and this is the series of reviews and meta-analysis, and this is the forest plot, and individually, each of the studies have shown that metformin does reduce the growth and clinical events of abdominal aortic aneurysm. And when you combine all these reviews, comprising of over 5,745 patients compared against the control of 10,000 patients, and metformin definitely reduced the growth of abdominal aortic aneurysm. This is again another meta-analysis, systemic review and meta-analysis to see the role of metformin in controlling the growth of aneurysms. Again, this forest plot shows that this forest plot favors the use of metformin in controlling the growth of abdominal aortic aneurysms. Now, let's move on to statins. Again, I'm going to show you a series of results, reviews, and meta-analysis with the use of statins. But in these studies, in these reviews, what they looked at, how the statins reduce the growth rate of the aneurysms, rupture rate of the aneurysms, and perioperative mortality in these patients. Now, this is one such study where there were 22 studies were included in this review process that comprised of over 80,000 patients, where statin use controlled the growth rate of the aneurysm. There was a lower rupture risk and lower 30-day mortality. And if you compare the crude mortality rate between the control and the group received the statins, in the statin group, the mortality rate was 1.8% compared to 2.66% in the control group. So undoubtedly, this review and meta-analysis did suggest that statin has got significant role in the abdominal aortic aneurysm growth and rupture risk. This is another review and meta-analysis. Although one thing that is quite prominent in this meta-analysis is that if you look at the heterogeneity in the study, the I-square is about 86%, suggesting that there is a significant heterogeneity in these studies. Therefore, even though there is significant factor here suggesting that use of statin does reduce the growth rate of aneurysm, the rupture rate, and the mortality rate, but one has to take this message with a pinch of salt because there is a lot of variability between these studies in this review. This is another review and meta-analysis. Of course, different authors have contributed to this, and this is comparing patients who were on statins, about 1,680 patients, compared to control, which are 3,600 patients. But again, if you look at the heterogeneity in the study, it's quite a large heterogeneity, significant heterogeneity. So therefore, one has to take the results with a pinch of salt. This is again further result, although it is a small study, but again, it is quite convincingly suggested that there is some role of statins in all these patients. And finally, overall, if you look at the individual reviews by these groups and also the final review, all of them together concluded that statins does have got significant beneficial effect in the control of the abdominal aortic aneurysm. And here, in this particular review, the heterogeneity is much less compared to the previous reviews that I presented to you. So one group from UK, they did a meta-analysis and reviews of all the role of statins in controlling the aneurysm growth. They were not convinced, and they suggested that we definitely need the performance of a large-scale multicentral randomized study to confirm whether statin is beneficial in the control of abdominal aortic aneurysms. And another author who published an editorial, he was so convinced about the role of statins and metformin that he concluded that I think the experiment with the drug development in the control of aneurysm progression has come to an end. We should start using statins or metformins in the control of aneurysms. So in conclusion, there is undoubtedly evidence for statins and metformins for controlling the growth of aneurysm, for reducing the rupture risk and reducing the perioperative mortality following surgery. But as I said, that there is a high heterogeneity in all the studies, all these reviews and meta-analysis, and therefore I feel that there is an urgent need for a large multi-center randomized trial to confirm the beneficial effect of all these medications. Thank you.
Dr. Das, on this talk, thank you for the nice talk. Do you can one extrapolate the findings and statins and metformin to thoracic aneurysms?
I think it is the similar story, isn't it? Because as you can see, the statin and metformin, this was study of the large database of patients, like say in diabetic patients who are already on metformin and who have also got abdominal aortic aneurysm. Yes, it is possible to extrapolate the data, and not extrapolate that one can conduct a study of retrospectively to look at the data in these patients with thoracic aneurysm, whether metformin has got any beneficial role. And nowadays, most patients are already on statins anyway. So we can always find out the data from those databases.
Thank you. That would be interesting also for medically challenged communities where the need for surgical intervention may be cost prohibitive. Maybe if they're placing these medications ahead of time, we may be able to decrease the need for intervention. Can't say yet, but something to look into. I find in my travels that there's an increasing rush of thoracic and abdominal aortic aneurysm in Nigeria, which is quite interesting. The literature doesn't seem to think that there's that much aneurysms, but there is indeed a lot more. And we're finding a lot of younger folks in the 40s with rather large aneurysms in the 8, 9, 10 cm range. And that's kind of interesting because, again, for some of these patients, they cannot afford endovascular intervention, which is not readily available. And the only hope would be open surgery. So that's something also that we're dealing with right now in this in the sub-region. Any other questions from the virtual audience? Yeah. A question is, can you prescribe the metformin to patients ordinarily with abdominal aneurysm, even if they don't have the other comorbid condition like diabetes?
We know that metformin is the drug of choice many a times to patients who are obese, who have morbid obesity. So I think I cannot assure you that you can safely prescribe metformin, but there are examples where metformin has been prescribed in non-diabetic patients, particularly in cases where there is morbid obesity. That's what I know.
What any association with doxycycline as part of your research? I know.
I picked off particularly these two medications, metformin and statins, because although doxycycline, NSAIDs, and even ACE inhibitor and ACR receptor, all these have been tried in animal experimental study and have shown some beneficial effect in controlling the growth of aneurysms, but human studies that did not establish the same beneficial effect as it was with the animal experimental study.
Okay. I think there's one more question from the virtual audience. Yes.
Dr. Okuri Leonard said, "Thank you for the presentation, sir. I wonder if these researchers tried to indicate the mechanism of action of these drugs, metformin and statins, in reducing abdominal aortic aneurysms."
Yes, as I showed you in my initial slides, the mechanism of aneurysm development, how inflammatory cytokines, how acute inflammatory markers and destruction of the matrix metalloprotein that constitute the development of the aortic aneurysm itself. So these medications, and in one of my slides, I showed you how metformin works and how statin works. Particularly, I'm very impressed with the statins because statin has got anti-inflammatory effect, antioxidative effect, and it also helps in the production of matrix metalloprotein. So for that reason, I mean, we have to conjecture that that is how statin works.
Thank you.
Proceed.
Yeah, you can proceed to your next presentation.
Okay.
Thank you.
Thank you. Thank you. Okay, can you see my slide, please? Can you see my slide?
Yes, we can.
Thank you, thank you. So let's move on to my next topic, which is about surgery and endovascular surgery, about the aortic aneurysms. But the aortic aneurysm that we are going to talk about is not the standard simple aortic aneurysms. These are the so-called juxtarenal or pararenal abdominal aortic aneurysm. Now, over the years, I think I would say for the last 25 years, the procedure that we normally consider for juxtarenal aneurysms are the so-called fenestrated EVAR graft. And this has been quite routinely performed in many centers who have got the expertise and the infrastructure for the procedure. And if they can afford, because fenestrated EVAR procedure is very expensive and not that every center can afford such a procedure. If I give you an example, if you are doing 2 fenestration or 3 fenestrations, the fenestrated EVAR graft will cost somewhere around 25 to 30,000 pounds in UK. So it will be somewhere around $30,000 to $35,000 in United States. So we always thought that whether we can think about other ways of treating these patients so that they can benefit from the procedure. And we all know that many times, even those standard aneurysms, what we call as the standard aneurysms, they may not be suitable for conventional EVAR graft according to the IFU of the device companies. But we extend the IFU so that we can perform a standard EVAR. Ultimately, the consequence of this is that many of these patients are readmitted for secondary procedures to correct the problems, which would not have happened if we had considered a PVAR graft at the beginning. So in order to address this issue, we have to think about other ways of helping these patients. And one such help comes from CHIVAR, which is the chimney or snorkel or periscope graft together with the standard EVAR graft. So we have the experience of performing the PVAR graft as well as the chimney graft here in London. So that's why I'm presenting some of our experience, but also I'm looking at the results of the registry, and that gives the long-term mortality and the patency of the limbs and the stent devices. Now, if we look at when the fenestrated stent graft concept was introduced somewhere around in 1996, since then, Cook's Zenith fenestrated graft has been performed over 5,000 or 6,000 patients. And similarly, Vascotech anaconda PVR graft is also been performed over 2,000 patients. Now, I have particular experience with Vascotech anaconda in performing the PVR graft, whereas Cook Geneth is the most accepted procedure all over the world for fenestrated PVR graft. By contrast, chimney graft, which has got a relatively less experience as it was with the fenestrated PVR, chimney graft was introduced by Greenberg in 2003. But if you look at the recent publication by Pericles Registry, and it compares the results of the CHIVAR or chimney EVAR graft of 517 patients together compared against the PVAR graft using the fenestrated EVAR device. Now, there are situations when we may not be able to perform fenestrated EVAR graft because of the anatomical problem or geometrical of the aorta, such as small tortuous iliac arteries, severe iliac occlusive disease, and if there is endoleak, type 1A endoleak or angulated aorta, and in those situations, we might not be able to consider a fenestrated EVAR graft. And also, as we all know, that if we don't have the P graft, then even in life-threatening aneurysmal rupture situation, we might not be able to consider a PVAR graft. And if an aneurysm is rapidly expanding and painful, in those situations, one cannot wait for the PVAR graft to be available for deployment. So there is an urgent need for considering other ways of managing this patient with juxtarenal aneurysms. So one such example is the chimney graft. Now here I'm showing you the chimney graft that has been applied together with the standard EVAR graft in one of my patients. But the problem in chimney graft is this, that the branch vessels where it is, like in this patient, he had a graft in the renal artery, which we had to rescue by secondary intervention at a later stage, but ultimately that renal artery was thrombosed. So this patient lost his renal artery following chimney procedure, CHIVAR procedure. This is another case where following the procedure, it was noted that the stent is compressed by the main aortic stent graft. As a result, the patient lost the renal artery. So there are problems with the chimney graft, but even having said that, this can be done with careful attention to various details, and it can become an alternate to PVAR graft. What I'm showing you now, the results of the anaconda PVAR graft, and we performed this over 2,000 patients. What it's showing, the immediate complications in these patients involved cerebrovascular accident, and this was largely in patients where the cannulation was in the upper limb. And in these patients also, limb ischemia occurred in about 4 patients, multi-organ failure occurred in about 11 patients. Whereas renal complications occurred in about 10 patients. Out of the 1,600 patients, there were PVAR anaconda procedure was performed. And if you look at the long-term result, again, there were 4 patients who had limb occlusion at 1 year follow-up, and 3 patients had limb occlusion at 2 years follow-up. Apart from that, most of these patients did have a very good result. And then when we looked at the occluded vessels, how many patients had occluded vessels when we followed them up after 1 year, 2 years, or 3 years, there were 11 who occluded at 1 year, but subsequent years follow-up, only 2, and subsequently 1. In the 4th year follow-up, none of these patients lost their target vessels. So this is now in comparison to the Pericles registry, which gathered the results of CHIVAR procedures, that means chimney-EVAR procedures, and what was lacking until now was the long-term result of this procedure. And this is the 5-year follow-up of chimney procedures. And here, the perioperative mortality at the end of 5 years was patient who survived. 65% of these patients survived 5 years following the CHIVAR procedures. With regard to the results of the patency of the graft, almost 90% of the patients, their grafts remain patent at the end of the 5 years. And the same result also, primary successful result occurred in about 88%, and the branch graft remained patent in about 92% of the patients at the end of 5 years. And if you look at the factors which contributed to the failure of the chimney graft are two things. One is if the sealing zone, aortic sealing zone diameter was more than 3 centimeters, then this considered to be an adverse factor for chimney graft. And secondly, if there is no infranal neck in these patients, then that also contributed to be the adverse factor in the long-term patency of the chimney graft. Now, we also compared the cost of the primary procedures with FEVAR and also compared that with the CHIVAR. As I was saying at the beginning, that FEVAR cost is pretty high compared to the CHIVAR graft. Now, it is the cost of the primary procedure, which is in terms of euros, is about 42,000 euros for primary procedures, compared to the chimney-EVAR graft, which is only 22,000 euros. Whereas the cost of first readmission, subsequent readmission is not as significant as the primary procedure itself. So there is a significant cost difference between the two procedures. So that is something which is very attractive in considering the chimney-EVAR graft. And if you compare the FEVAR graft with the CHIVAR graft in various, and look at the 30 days mortality rate in various series that compared the 227 patients with FEVAR compared with 126 patients who had CHIVAR, and there was no difference between the two groups. There were 10 events in the FEVAR group, whereas there were 6 patients who died in the CHIVAR group, but these results were not significant. If we look at target vessel occlusion between the two groups, in the FEVAR group, there were 325 patients, of which 7 patients had target vessel occlusion, compared to 5 patients who occluded in about 123 patients. And again, there was no difference in this forest plot between the two groups. But surprisingly, if you look at the number of times we perform fenestrated EVAR or open aortic aneurysm repair, the proportion of the patients who undergo FEVAR is almost similar to the open repair. But despite the beneficial effect of despite having no difference between the chimney graft and the fenestrated graft, only 9% of the procedures were performed by CHIVAR. So this is something needs to change, because many patients can benefit by chimney graft where they will be considered unfit or anatomically unsuitable for consideration of FEVAR graft. So in conclusion, this comparative studies shows that long-term outcome for CHIVAR appears satisfactory. Although CHIVAR is not as popular as FEVAR, as my previous slide showed, the outcome data is encouraging. So the choice of which device to be used, it will be determined by the geometry of the aneurysm, where FEVAR cannot be considered. The size of the entry vessel, again, remains a contraindication for FEVAR procedure. Availability of the device and expertise. As I said, the FEVAR, to deploy a FEVAR graft, it takes at least 6 weeks for custom-made fever graft to be available for that particular procedure, and also adequate and the expertise need to be available to perform the procedure. And timing of intervention in emergency, even sometimes P fever, Cook's P fever graft, Zenith fever graft may not be suitable. And in those situations, one can consider chimney fever graft. And finally, which is the most important thing, is the cost of the procedure. As I showed you earlier, that fever is less expensive compared to the fever graft. So I think there is a role for fever graft in patients with juxtarenal aneurysms, and this should be considered in most of the centers who do not have the expertise for fever procedure. Thank you.
Okay. Thank you, Dr. Das, for that interesting talk. A few questions from the audience. I don't know. If not, I have some. Okay, I have some questions for you.
Sure.
In London, are you doing your chimney grafts in centers such as yours, or community hospitals can do them?
As I said, that not many centers are expert in even performing the chimney procedure. And we do chimney as well as fenestrated revar. And so we have got that luxury of comparing between the two procedures. Sometimes when we think that probably chimney is, even in emergency also, we have found that it is better to do chimney procedure than waiting for a custom-made fever procedure.
That's correct. Next question for you would be, for the benefit of the non-surgeons in the audience, could you talk about the operative steps for the chimney procedure so they can have a better read on it?
So the steps of the fever procedure?
Of the chimney, yeah, correct.
Okay. Well, the important thing for the fever procedure is this, that you have to decide whether you are coming from above or you are coming from below. And particularly for the, say, celiac or SMA graft, we tend to come from above. And whereas for the renal vessels, we tend to come from below. And this is one thing what we consider as important for us to do. And then once you have decided which route, access route will be the most suitable, then once you apply the chimney graft, then you deploy your standard fever graft over the chimneys.
I remember in the mid-90s with Dr. Dietrich, and when we were at Arizona Heart, we used to do a lot of homemade grafts. And how would you advise the surgeons who are in medical challenged communities, say in Africa and other parts, to adapt the achiever concept? And what grafts would you think, or how would you advise them to go about that?
I think it is, what do you call it, this physician-made fenestrated grafts have gone out of favor, as you know, that
Sure.
On the table, constructing the fever graft, making the holes and doing this is a much more tedious procedure. So in that sense, deploying a chimney graft is much easier compared to performing on the table fever graft yourself if you can't afford the custom-made fever graft. And I don't think that it is that difficult to perform a fever procedure, particularly doing the chimney deployment, as long as you have considered the geometry of the aneurysm, the geometry of the branch vessels, and like one of the slide that I showed you, where we did the chimney graft, we thought that that was one of our best procedure that we did. But ultimately, after 1 year follow-up, we saw that the left renal artery is being gradually getting narrowed, and we found out that there was a shelf where the stent was hitting the renal artery, and that was the cause of the problem, which ultimately occluded the renal artery despite secondary intervention. we lost that renal artery. So those are the things which we need to keep in mind, that this subtle and simple problem which can cause the loss of the branch vessel, that is to be taken into account.
Yes, one question from me and one more from the audience, virtual audience. For a healthy patient who presents with a juxtarenal abdominal aortic aneurysm, is there a role for open surgery?
Well, I showed you how people do. There was almost 50% of difference between PVAR and open surgery. So I think there are people who are still doing open surgery for juxtarenal aneurysms. Now, in our institution, almost 80 to 90% of the procedures that we do, fast endovascular procedure, even for lower limb bypass, lower limb ischemia, we will do endovascular surgery first before we do consider any open bypass procedure. So yes, there are institutions who are still doing open procedure for juxtarenal aneurysms.
One question from the virtual audience, Dr. Das.
Yeah.
Can the doctor please say if these two procedures are available in the NHS in the UK?
Yes, it is. It is available in the NHS, yes. The NHS is very rich, even paying for the PVAR graft, whether it costs 25,000, 30,000 pounds. But the only thing the NHS wants to see that you have got the expertise, you have got the infrastructure in your theater, the cone beam CT, the hybrid suite, all these things are there. That's something.
Thank you.
Very well, Dr. Das. Thank you so much, and we appreciate your helping us out with the conference this year, and look forward to seeing you next year. We also do have the global ground rounds, and please have your residents and medical students, if they have interest in cases, they can join us and join the platform. We have it every quarter. Our next one hopefully will be in December, and thereafter every 3 months. We have interesting cases from around the world. They can join in, let us educate one another with interesting cases. Do appreciate your presentations, are very timely, and we do know from the audience now that we have some optimal ways of treating abdominal aneurysm medically. We've been doing that for years, and with the option with Metformin and statins, we'll definitely take that into more consideration, especially in medically challenged communities, of course. So thank you again, Dr. Das. Appreciate it.
Thank you. Thank you. All the best.
London, take care.
And you could just unshare your screen, Dr. Das?
Yeah.
Thank you.
Okay. Our next speaker comes to us from the state of Indiana. She's Dr. Cuddy. She is an endovascular surgeon. She is an assistant professor of surgery there at University of Indiana. And she also did her endovascular training, vascular training at the Burr Heart and Lung in New Jersey. She spent a short or brief period of time in West Virginia, and then proceeded to, I believe, a couple of the states before she landed finally in Indiana. So on behalf of our Endovascular Conference, I'd like to welcome Dr. Cuddy and look forward to her presentation.
Thank you, Dr. Oye. It's the sound okay?
Yes, perfect.
Yep.
Wonderful. Thank you.
Just before you begin, sorry, Dr. Das, your screen is still shared, so.
Oh,
we'll
sorry.
Sorry. Yeah.
Yeah, I'll just.
Thank you. You're good to go, Dr. Cuddy. Thank you.
Thank you. Thank you, Dr. Oye, for the very kind introduction and the invitation, and good morning and afternoon for some in everybody, and honored to be here. So today I would like to presenting the new endovascular technology innovation that we had been successfully able to utilize and use to treat the patient, which is the it is the percutaneous mechanical arterial advanced thrombectomy technology, which is the expanded vascular surgical technology. objectives. And so the acronym of the protocol, the treatment, it called FODMAT, which is first order percutaneous mechanical arterial advanced thrombectomy technology. This developed actually from the conventional vascular technology that when we have a standard of care, which is we know as an evidence-based, that it is effective, it is safe, that we are thus far, we know that we can use those treatment options for the patient. However, in some circumstances, we facing some challenging and consideration of risk and benefit to those treatment plan, and curating those plans to each patient that we have. So sometimes it can become very challenging. So in this specifically, we are dealing with the complication of the limb graft occlusion and thrombosis after aortoiliac stent graft implantation. The study that was done and report in 2004 that the implantation of the stent graft, which has been expandingly increasing numbers of those procedures, they found that limb graft occlusion actually is not at all rare, and yet nonetheless it represents a very serious complication of the limb occlusion and limb graft. It is the third most common reason for the patient being readmitted after EVAR treatment. And generally, traditional surgical treatment options are the most considered option for treatment. However, endovascular treatment is usually also very possible. In this study that was done and report in 2021, over 900 patients that had standard EVAR as a primary intervention with infrarenal AAA, and the majority of them are male patients. This is the retrospective cohort study. So they found that limb occlusion actually occurs in at least 5.9% in this study. Mostly is Zenith, and second is Endurance, which is Medtronic, and then thirdly is Gore. So apparently this report, the number of 5.9% of limb occlusion thrombosis is actually more than what reported in the US database. So it makes me wonder that it's indeed actually a underreport type of situation. Study was done in China. There were 66 cases of patients that had EVAR treatment from 2005 to 2013. And there were 7 limbs that was occluded within 12 months after the treatment. So the patient underwent mostly thrombectomy and surgical repair, which appeared to be successful. And 1 case underwent conservative treatment without any surgical intervention. So there was no mortality outcome in this study. So when we're facing this situation, all of our patients would be a surgical candidate, and sometimes they may have multiple comorbidities at once, along with the complication of the endovascular limb thrombus. Is there any other alternative therapy that we can help our patient to help decreasing morbidities and mortality for the patient in this such a devastating complication after the limb graft thrombosis, and preventing limb loss as well? We have published from our institution, the first case report that was published in 2022. in Journal of Vascular Surgery in case Innovation and Technology. The case was 64-year-old male. He was heavy smoker, very severe COPD. He had 3 months present to the emergency room, 3 months after EVAR for AAA repair with symptomatic limb ischemia and limb threatening. He underwent percutaneous thrombectomy with ipsilateral and contralateral embolic protection with the self-blood return system. IVUS assist to investigate the underlying limb occlusion and then treatment with relying the limb graft occlusion. So with the technique, which was not approved by the FDA, we using the technology actually from the venous thrombectomy to mix with the arterial thrombectomy catheter aspiration. And there was no TPA use, so therefore no need for ICU stay. It was totally percutaneous with endovascular closure successfully with perclose on the ipsilateral limb. Ambulate, he was able to ambulate and discharge home on the next day. At his 18-month follow-up with CT angiogram, arterial Doppler, it was found that his aortobiliac stent graft was remained patent without any sign of complication. He was placed on dual antiplatelet for 6 months along with fully anticoagulated for 6 months, and then after 6 months, he. So this is the stent graft, and we can see the left limb was occluded, and the right limb was maintained patent. And so we did the protocol of the percutaneous thrombectomy. This is the post-operative picture that the angio run off, very robust on both limbs. And this is the thrombus that was removed from the left aortoiliac stent graft. So the protocol made of bilateral percutaneous access and angiography. So during the access and deployment of endovascular closure on the ipsilateral, we also utilize contralateral embolic protection with balloon embolic protection, percutaneous mechanical aspiration thrombectomy of the thrombosed limb, the embolic protective mechanism on the ipsilateral side by using the funnel sheath, which is the adapted, the utilization from the venous thrombectomy technology, and also along with the self-blood return system. The IVUS was used to assist investigation the underlying problem of the stent graft. Then bilateral percutaneous endovascular revision of the endoprosthetic stent graft as needed per diagnosis at the time. Then completion of angiography and confirmation of the limb Foley expansion with IVUS as well. With this protocol would allow the patient to remain treatment and post-operative observation outside the ICU because we don't need to use the TPA, no PAC RBC transfusion, and the patient was able to ambulate and discharge within the next day. On post-operative follow-up protocol, we utilize, as I say, dual antiplatelet and anticoagulation for 6 months. After 6 months, we reduce to 1 antiplatelet and statin medication to remains, and follow up with arterial Doppler, ABI, along with CT angiogram of aortoiliac area. This is the cartoon drawing to share the image picture. So this is the limb occlusion, the clot, the funnel sheet deploy on the ipsilateral to the clot area. We have to be aware that the access vessel is suitable for the perclose device, as well as the distance between the clot, the thrombus limb, and the access site enough for the sufficient length for the deployment of the funnel sheet, and the contralateral balloon occlusion were also deployed, inflated on the contralateral to prevent contralateral embolic protection. And so we are on the process of a PubMed protocol clinical trial that we're hoping in the future that we will be able to conclude and include within multi-institutional support and collaboration with along with the regulatory IRB sponsor. And what actually happens is I'm hoping that the investigation and the clinical trial will lead to the approval that we can assemble the complete interventional kit, and this kit we can distribute throughout any region in the world, in the country, that it can be utilized in the fluoroscopy imaging and be able to help other people, other patients in the different region as well. So I'm hoping this will be benefit to both regional underserved, because our hospital currently we're practicing in the regional academic health center, but we are considered to be a rural academic region. We are not within the metropolitan. That's where the protocol is originated. So far we had done approximately 5 cases so far that we did treat the patient under the PubMed protocol. All patients had been fully disclosed about utilization and adaptation using the protocol outside the IFU, and this is out of the FDA approval. Male to female 4:1 ratio. There was 1 AAA initial graft implantation, 1 for AAA repair, and 4 of them for occlusive disease. The success of the intervention was 100% so far. In average hospital length of stay is 1 day. However, one prolonged length of stay in one patient was due to medical, that the patient has UTI at pre-existing pre-treatment preoperatively, and the hospital has decided to keep the patient a little bit longer due to vascular intervention. They want to make sure the patient optimally treated with IV antibiotic prior to discharge. Our median follow-up approximately 6 to 18 months with CT angiogram, abdomen and pelvis, and lower extremity arterial Doppler with ABI and TBI. So far, we have patency approximately 100%, which is for us it seemed to be very promising. And I would like to end this presentation with a little note from both of the philosophers and humanitarian, Dalai Lama. He said that if you want to be happy, we should practice compassion. And again, this intervention is actually based on the compassionate practice to our patient. Dale Carnegie say that inaction breeds doubt and fear. Action breeds confidence and courage. So that's why we proceed these intervention, even though we are within the rural community hospital setting. Yes, and thank you.
Thank you, Dr. Cuddy. Nice talk. I appreciate it. Any questions from the audience for Dr. Cuddy? Because you know I have one. Dr. Cuddy, when we work with difficult patients and you have a iliac intervention like you've shown, and you have limb occlusion, well, you would agree, like a lawyer would say, you would agree with me that the reason for the thrombosis sometimes because they have disease process at the common femoral level, i.e. calcification. So if you're doing complete or total percutaneous interventions only, how do you account for the calcium burden that may be there that may cause significant problem? Do you think a limited percutaneous procedure on the contralateral side with the balloon, granted, and on the symptomatic side with limited hybrid intervention could be helpful, especially if you don't have the complement of device factors that you may need, and that will also preclude you from using the constant embolization distally because you can really put vessel loops or clamps distally while you attack the proximal portion with your percutaneous technique.
Yes, that is a great question, Dr. Oye. That's why the funnel sheet, which is actually the venous thrombectomy sheet, the Trieber sheet, it is a great utility, and it can be safely deployed under 035 wire. The disadvantage is that you have to have the distant room between the access site and the between that and the clot, approximately 4.5 to 5 centimeter. And yes, the access site, it has to be at least 60% anterior wall of the common femoral artery to be free of calcium. So I normally use, if there is room to go in with a little calcium, if there's a little room for me to access, I use ultrasound guided percutaneous access, and your access is very precise. Access be very precise too. And yes, if it is a heavy access site, then I would have to cut down, definitely, so you can
The most valuable chip for a while ingredient given us the with a reaction is when we keep some hardware.
Sorry, Dr. Cuddy, there's connection.
okay.
Success in ascending smartphones.
Can you imagine, say, my phone will just break phone now.
You can continue now, Dr. Cuddy.
Okay.
Dr. Cuddy, go ahead.
I agree with you, Dr. Oye. I think, if it's heavily calcified and it's not suitable for percutaneous access and deployment of pre-close, then I would cut down. And the limitation, the problem is with cut down, and to utilize the IVUS afterward,
You can't do anything.
it's more difficult to get the sheet in there. But I think it's probably doable to try to get IVUS up to interrogate the limb construction, how the limb is. I never try it to use IVUS under cut down open. I think that would be very interesting, expanding for the troubleshoot.
Yeah, again, the whole idea, I mean, I respect the value of what you presented. I'm always thinking that when you are in a difficult situation and you don't have all the tools available, you have to kind of think outside the box and how you could probably solve such problems. The percutaneous on the contralateral side makes great sense to prevent embolization. Then the maybe depending on the level of calcification or blood burden at common femoral level, open that area and controlling the potential for embolization downstream on that ipsilateral side would make sense, because now you have more complement. Not only can you do percutaneous easily, You can even drop a Fogarty catheter, you have to, and if you have to really declot a whole lot more, you never know. So that's just one of the things I would look at if I were to adapt the technology. I've done it this way also. Thank you so much.
Yeah.
Dr. Kadi, we look forward to seeing you in our global ground rounds. Next one will be in December. And again, on our endovascular conference for next year, we would like to hear more about your technique and your progress and any other interesting information you want to share with us. On behalf of the Endovascular Conference for Africa and Rural America, it's my greatest pleasure to again thank you very much for helping us out this year. Thank you.
Thank you, Dr. Oye.
Okay, you can. Thank you, Dr. Cuddy.
Yep, she's there.
Okay, our next speaker would be Dr.
Unscreen my.
Okay. We'll wait you to on screen. That's fine.
Yeah, I'm not sure that I lost that function.
Okay, we'll do it for you here.
Okay, thank you.
Maybe no, you have to do it. We'll wait for you to do it. She's trying to get up.
Dr. Olson?
No, Dr. Cuddy wants to get up.
Oh. Dr. Cuddy, your screen is unshared, so you're all good.
All right.
Thank you.
Thank you.
Thank you, doctor. Okay, our next speaker comes to us from Arizona, USA. Dr. Dawn Olson is the current president of the Edward B. Dietrich Vascular Surgical Society. She is an endovascular vascular surgeon who practices in Arizona. She had the distinct pleasure to have worked with Dr. Dietrich, not only as with Dr. Dietrich, primarily as a PA prior to going to medical school and becoming a vascular surgeon. She does have a first handle on some of the do's and don'ts of Dr. Dietrich because she worked with him for many years. On behalf of our conference, again, would like to welcome our current president of the EBDVSS, Dr. Dawn Olson, who will be presenting to us today. Dr. Olson?
I think I need a few minutes. I'm not being able to share
Sure,
my.
no worries. Take your time.
Okay, thanks.
Just let me know if you need any help, Dr. Olson.
Yep, I'm working on it here. My setting. If not, can I do it through this? No. Okay. Let's see here. What if I do it through here? Go in here. If I go into here, and then let's try that.
Recording.
It says you're sharing your screen now.
It does?
It does. It does.
Great.
You just have to switch it to the presentation slide now.
Yep.
There's some feedback from the sound in case you have two audios on.
I do. I was trying to do it through my phone because it wasn't coming up through my iPad.
Okay.
So hang on a minute. I don't know how to. You're sharing. Hang on a second. All right. All right, so let's get that one away. All right, I'm not able to get in there yet. Maybe you should go on to the next one and I'll try to see what I can figure out, okay? Because I'm here, maybe I can do it through this and not that one. Okay. So.
If you'd like us to go to the next presentation, we could do that. And
Hey, Don, we'll go back to another presentation, come back to you, see if you can figure that out. Is that
Yep.
good? Okay,
Yep,
let's do that.
Thank you. Okay.
Text, just text us and let us know, all right?
Thank you.
Now?
there, you have to say, yeah.
Okay. All right, so we had some mild technical difficulties, so we'll shift the schedule a little bit. Our next speaker would be Dr.Divya Rajan. She is a consultant nephrologist here in Beckley, West Virginia at Raleigh General Hospital and the other hospital in the area, Beckley Hospital. She has been in the community for several years and has an active practice taking care of renal patients. We depend on her for managing our sick renal patients, and we're quite grateful she's always there. She's also the outgoing chief of medical staff for the hospital, Raleigh General Hospital, and we look forward to her talk this morning. Dr. Rajan, you ready?
Yes, sir.
Okay, let's do it. Welcome, Dr. Rajan.
Yanni?
Yes.
Oh, nice to meet you,
Nice to meet
Yanni. Okay. Now I can just use this.
Yes, ma'am. Just. Perfect.
Okay, perfect. And then I guess I can do arrows.
Yeah, or you could even click it.
Oh, okay,
there.
perfect. Thank you so much, Dr. Oye, and thank you for asking me to speak today. This is a wonderful thing, and I've been looking forward to it. My name is Dr. Rajan. I'm a nephrologist here, as Dr. Oye mentioned, and today's topic that I wanted to go over was volume assessment in the intensive care unit. Is it an imperfect science or an art? And my objectives are to discuss techniques of volume status assessment in the intensive care unit, learn about the benefits and deficiencies of different tools of assessment, and to integrate different tools and approaches to volume status assessment at bedside. As many of you know, even outside of the ICU, it is very difficult to sometimes assess volume of a patient, and it becomes a clinical quandary. And so this patient here is an example of patients we see almost every day. A 55-year-old man with pneumonia, his heart rate is high, his blood pressure is low, he's on the ventilator. His ejection fraction's not bad. He's got a temperature of about 101 degrees Fahrenheit. We've given him a bunch of fluid in the emergency room. CVP is being recorded as normal. Lactate's high, creatinine's not bad. So just by looking at this, many of you may say, give the patient fluid, and many of you may say, don't give the patient fluid, right? And I put this slide here to be funny because my husband's a cardiologist. And, cardiologists and nephrologists, we tend to differ on whether you want to make the patient wet or make the patient dry. But even you in this room, without saying anything, some of you might have said, give fluid to that patient. Some of you might have said, don't. And so that's the question. What should we do? I'm hoping that by the end of my talk, we can come up with some more ideas of how to help us figure that out, because sometimes it's not easy just by looking at the patient. But just by looking at the patient, which is important, a good clinical exam is always important. What are the things we typically look at? So we're always looking at the patient's mental status. What is their respiratory rate? What's the quality of their pulse? Is the heart rate high? Are they diaphoretic? What is their temperature? What is their urine output? capillary refill time at the bedside, pressing the tip of their toe or fingers and to see if the blanching improves and how long that takes. Skin modeling and shock index, which is the heart rate divided by systolic blood pressure. So these are the things we're all taught from the beginning of medical school to look at, and they're still important. They're still very important.
I'm sorry, they can't see your slide, so I'm just
Oh,
gonna
okay.
fix it. I'm so sorry for the interruption.
They're only for Beckley. They're copyrighted only for Beckley.
Okay, you might have to just do it from here. Yep. So sorry to
No, that's
interrupt.
okay.
Yeah.
No. I remember being a chief resident involved with audiovisual. It was the worst time of my life. Where's my arrows now? Maybe I'll just use this. No problem. Let me see the arrows here.
Yeah.
Down or up. Okay. So yeah. So again, these are the things we always look at bedside, right? Well, studies have shown that we are not that great in assessing those things. We assess them, we think we can decide based on all of that, which is what we do every day. We look at the patient at bedside. Turns out we're only 50% of the time right on what we're thinking about the patient's visual status. So we are not as good as urine sodium or measuring the plasma renin-aldosterone activity. So 50%, half and half. Okay, so that's not really a great statistic there. How can we increase those chances? That's hopefully what I'm going to go over today. Okay. So in addition to the clinical factors, there are static measures. In fact, that patient I showed you, we had a CVP, we had an ejection fraction, we had a lactate level. Again, these things on the right side of my slide, we have ready for us when you walk in the room, right? The nurses have this information, it's on the screen. So now this and the clinical together, are we doing any better? That's the question. But before we get to that, it's important to know that inappropriately giving too much fluid or fluid overloading the patient does have clinical consequences. And I have to keep this in mind as a nephrologist because we tend to like to give a lot of fluids, but sometimes it can be detrimental. So various organ systems can be affected if you're giving too much fluids inappropriately. A lot of liver congestion, central nervous system, there's a rise in intracranial pressure. There is cerebral edema, possibly. The abdominal wall, there's tissue edema, poor wound healing, pressure ulcers, more chance for wound infection. Gastrointestinal malabsorption, increased intestinal permeability, bacterial translocation, ascites formation, gut edema. Cardiovascular, of course, decreased ejection fraction, poor cardiac output, poor contractility, conduction defects. Respiratory, the obvious, pulmonary edema, pleural effusions, prolonged ventilation support, increased work of breathing. And of course, renal, despite giving fluids, you can sometimes actually reduce renal blood flow. Kind of counterintuitive, right? We think anytime you give fluid, you're going to be helping the kidneys to perfuse, and that's not necessarily the case. If the patient's physiology doesn't want fluids, you actually are going to increase venous pressure, decrease renal blood flow, and that will then in turn activate the renin-angiotensin-aldosterone system. Now you become more salt and water retentive, and you're causing more trouble. So yes, fluid is a drug. When you order it, you have to keep an eye on it. You have to monitor it. It's just as scary as Coumadin. Okay, it's just as the same thing as a blood thinner. You have to think of it as seriously. So fluids can cause trouble if given inappropriately. So again, this balance of whether the patient needs fluid or not on this side or this side, are there dynamic variables that we can look at? And we're getting there. So some of these variables, we talked about clinical, what you see on the patient, and we talked about those static measures, CVP, things that are on the screen when you walk in the room. But some of these things we don't institute, and they're actually very, very good for determining whether a patient needs fluids or not. And what the data is suggesting is we need to use more of these measures at bedside. So looking at peak positive flow, tidal volume challenges, and expiratory occlusion testing, lung recruitment maneuvers, and passive leg res testing. And a lot of these actually work on how the heart and lung normally interact physiologically. And by looking at some of this data, it can predict whether or not the patient needs fluids or will benefit. Again, we're trying to balance this. If you give too much fluid, you can increase mortality, there's organ dysfunction, increased length of stay. And if you don't give enough fluids, you can have decreased tissue oxygenation, organ failure, and death. Before we go further on some of those tests I talked about, I want to remind you all of the Frank-Starling curve. You all learned about this in medical school. But again, normal physiology, you have stroke volume on the x-axis and your preload on the y-axis. And normally, like this blue curve here, by administering a fluid bolus, if the patient is able to respond, they will. You'll have improved ventricular function. But if the patient has decreased ventricular function by giving a fluid bolus, you will not see such a response. And so we need to determine if the patient is going to be here or if the patient is going to be here. This is someone who will do well with fluids. This is someone who will not. And then you get those complications with all those organ systems we talked about. This study is called the SOAP study, which again reiterated that fluid overload will increase mortality. So again, I want to reiterate that point. This slide actually shows you I always like to put in kidney slides because I'm a nephrologist, I'm biased, but it's important to know that there is a chicken and the egg type of phenomenon with renal failure and fluid overload. So if you fluid overload someone, you can in fact induce renal failure or acute kidney injury, but acute kidney injury in itself can cause fluid overload. So if you look at this graph right here, the dark blue are patients who have acute kidney injury, the light blue are patients who did not. But as you can see, as fluid balance is positive, there's an increase in length of stay in the ICU. So the more fluid positive they got, the more they had to stay in the ICU, whether or not they had renal failure or not. Similarly here, the more fluid they got, the more chance of death. Okay, so mortality increases with positive gains of fluid. So again, important to keep in mind, we like to give fluid when appropriate, but we have to be careful. And this is just a slide of the interactions. You know, it's very complex. On one side, you have someone that you diagnosed with intravascular hypovolemia. Again, difficult to do. Only 50% of the time we're good at it. Hopefully some of the tests I'll teach you about today will get that percentage up higher. But let's say you've determined they need fluid. Fluid, of course, stretches the endothelial wall, atrial wall, A and P to help with urine output. But then you're fighting against these issues here, sepsis and SIRS, there's endothelial dysfunction, there's capillary leakage, you get renal failure, which then leads to fluid overload, and then fluid overload leads to AKI. So it's not as easy as we think, right? There's a lot of things happening internally that we're always fighting against. The effects of fluid administration are not always consistent. Fluids can be harmful. So again, very important to assess fluid responsiveness. So again, we go back to this patient. So far, we're still kind of in the same spot, right? Some of you may be thinking, yes, give fluids. Some of you may be thinking, no. Let's see where we're going with this, okay? So one of the things we have found very helpful, you know, when you want to give fluids, rather than going full force with a big bolus or a maintenance dose, how about giving a small fluid challenge? This has been used a lot and the data shows this is very helpful. There are things called mini fluid challenge tests, small fluid challenge tests, and actually the data shows that that's very helpful to you. Even giving colloids 200 ml or 100 ml or 50 ml based on the CVP, and then seeing how the cardiac output does will give you an idea of where this patient is going, and you're not going to risk giving too much initially. In fact, our anesthesiology friends, they in the OR sometimes just give 100 ml of saline at the bedside, and they monitor cardiac output or systolic blood pressure, and then they'll decide if they want to go further. So this is kind of interesting. As I was reading about this, you know, giving 100 ml, that's little, but our body can respond, and rather than you overloading, this is good to keep in mind. Go a little bit and see how they do. This actually is interesting about some of those static measures. So central venous pressure. There was a meta-analysis of over 1,800 patients, 43 studies. The area under the curve was significance. Basically, what it's saying is be careful with central venous pressure. It is not as black and white as it seems. For example, in the patient I described, right, very high heart rate, very low blood pressure, not a great urine output. Immediately, if I told you this, you'd be like, give the patient fluid. And the nurse will say, but the CVP was normal. And then you're thinking, I know, but yeah, so the CVP sometimes creates more difficulty. And so the data is suggesting that you have to be careful. Don't trust the CVP. And we run into that all the time. Patient is dying, he's modeling, he's clammy, and the CVP is 23. It just makes no sense sometimes, whether it's the way the Swan-Ganz catheter is placed or other things, but don't go only with CVP. Okay, so that's an interesting thing to note here. Looking at some of the guidelines, Surviving Sepsis campaign, which came out in 2021, gave a lot of guidelines on septic shock, as well as this task force, both recommended that you have to look at other parameters, not just clinical and not just static things to determine fluids, okay? Urine output, something again, close to my heart as a nephrologist. I get phone calls throughout the night. Dr. Rajan, the urine output's low. The urine output's not great. And what do we as doctors do? We say, give fluid, just based on that. Oh, let's give a bolus. Go ahead and give some fluids. And that's not always the correct thing to do, okay? Studies do show that oliguria is a non-specific symptom. It is not always representing renal or systemic hypoperfusion. When you think low urine output, you think, well, they're not perfusing the kidneys, let's give fluid. But we already discussed that may not be the case. Actually, a low urine output may represent microcirculatory abnormalities associated with sepsis. And if it's truly low because of decreased renal perfusion, then it's a very, very late manifestation. So chasing urine output with fluids is a very high risk for fluid overload. And I've been discussing this after reviewing this topic for this lecture. I've been talking to our nurses here about this because it's a very common phone call. Urine output's low and the doctor just knee-jerk gives fluids, not always the right thing to do, okay? This is the global inception cohort study, which I put in here just to show what we're using around the world as fluids. This is a global conference. So obviously the most common is crystalloids. Crystalloids means anything that has the crystal sodium chloride dissolved in it. So normal saline is of course used a lot. Balanced fluids, this is your lactated ringers or Hartmann solution. And of course, dextrose combined with saline is given as well. Colloids are more proteinaceous substances, which are very good for depleting the vascular volume and the vascular tree. This is like HETA starches, albumin, gelatin, dextran. We don't use this as much here in the United States, but we do use albumin and HETA starch quite a bit if needed. This is a slide to just show what are the reasons we typically give fluids for, right? When the nurse calls you or you're being called, hypotension is a big one. Weaning off vasopressors, low cardiac output. Unfortunately, oliguria is still one. And of course, the static measures we talked about. But dynamic measures, which is what we're going to get into, not so much looked at. And that this number needs to increase is what the data is suggesting. We need to use dynamic measures more. So one of the dynamic measures is pulse pressure variation. And again, I had to review this because last I read, I was much, much younger in medical school. But really, it's very cool to see how the heart and lung physiology normally can predict if a patient's going to respond to fluid. So obviously, this patient would need to be on a ventilator so we can monitor these waves. And there's, of course, a formula. And thanks to smartphones, we plug in numbers, thank goodness. But by calculating pulse pressure variation, and if it's more than 12%, it very reliably predicts whether the patient will respond to fluid. So that is very cool. And again, we don't do this very much, but we can. We all are able to do this. You need a ventilated patient. You need probably a pulmonary technician at bedside. And you need to ask them to check these things on expiration, inspiration, and you can actually get these numbers. They're saying this is better than looking at a CVP. This is better than just looking at lactate. This is better than just looking at urine output. And we actually do have these tools available, okay? Again, that's the calculation. And again, I'm showing you how Frank-Starling relationship with looking at that. Stroke volume variation can also be done similarly. Again, you have to have the patient on a vent, so no spontaneous breathing, no arrhythmias, normal RV function. You plug in the numbers, and if you get more than 10%, it's also is a good prediction that they'll respond well to fluids. Again, better than just looking at the skin, better than just looking at urine output. These things are better predictors of fluid responsiveness. Tidal volume challenge. Normally, we provide a tidal volume of around 6 ml per kg. What they recommend is to increase it for just a minute or two to over 8 ml per kg, and then you check total lung compliance. Again, your pulmonary technicians will help you with this data. And if you get more than 30 here, fluid responses is unlikely. Less than 30, consider a fluid challenge. Echocardiogram is very important. Data is suggesting that we really need to institute echocardiogram, not only just transthoracic or TE, of course, these are more invasive, but there is bedside echoes available. It's called point of care ultrasound or POCUS. They're tinier machines that can be done at the bedside of the patient. and will give us information on cardiac output as you administer fluids, okay? The other ultrasound we use is IVC, okay? So we're finally getting something endovascular here in my talk. So endovascular compliance, I mean, the IVC compliance, the diameter, the stretch, by measuring this is a really good way of seeing if the patient is going to respond to fluid. It's non-invasive, inexpensive, easy, and reproducible. This requires probably a technician. You will probably need a technician to do this and give you the information. You can also do what's called VEXUS, venous excess ultrasound. So again, hepatic vein, portal vein, renal veins, all of these things, their stretch, their diameter, intuitively will tell you if the patient is volume depleted or not. So you get to actually see what's going on inside. Much better than just looking at those other parameters we talked about, okay? Other ultrasound tests include brachial artery velocity, carotid artery peak velocity variations, jugular vein distensibility. Again, can be done at bedside. You just need the human technician and the tools to do it. This test is interesting as well. It's called end expiratory occlusion test. So you have a ventilated patient, you wait till expiration is completed, and then you actually stop ventilation for just a little while. At that time, physiologically, your intrathoracic pressure drops, and you kind of auto-transfuse fluid into the heart, and it's supposed to increase cardiac output. So if you're able to witness that, that will also suggest a patient will benefit from fluids. Again, can be done. Takes a little bit of time, just a few minutes, but this is much better than some of the other things we typically use, okay? And finally, we have the passive leg raising test. This has nothing to do with heart-lung physiology. This is simply a maneuver. So the thought process is you have a ventilated patient in the bed. You first lift up their head 45 degrees for about 3 to 4 minutes. You allow the volume to go into the legs, and then you raise the legs and allow your body to auto-transfuse yourself with fluid. And there again, you should be seeing an increase in stroke volume and cardiac output. That means a patient will benefit from fluids. These are safer ways of predicting rather than just giving the patient fluid and then trying to catch up later when you've already caused damage, okay? So again, data suggests good results with a simple thing, a passive leg raising test. So take-home points, volume status assessment in critical ill is a science. It's imperfect. No tools without pitfalls. You need proper training, and formalized credentialing is still in process. Recognize your limitation, encourage wise integration of various clinical tools like POCUS, which is point of care ultrasound, in your daily practice. And that's all I have. Thank you.
That's a couple questions.
Oh, sorry. I was going to go sit there with my hand. I promise.
Any questions from the global audience first?
Not as of now.
Okay. What will be the value of our AI in this talk of yours?
Oh, I'm sure AI will have a role. All of those dynamic tests, I'm sure, can be monitored by AI and can be spit out to us at any time. So that's a very good question. I don't know what the role is. I haven't investigated that, but I'm sure it will play a role. Because a lot of these things are mathematical formulas from machines. Absolutely.
From a vascular surgical and nephrology standpoint, we do a large fixed surgery, either by femoral bypass surgery or AAA surgery, as the case may be, and patients stabilized in the operating room throughout the process. No issues of blood pressure. They may even be okay in the recovery with PACU, but as soon as they get to the ICU or CCU, they become hypertensive. And what do you do next? Do you give fluids? Do you just give depressant?
Yep. Always important to check some of these parameters. I mean, I would first, of course, look at blood labs. Has the hemoglobin dropped? Is there bleeding? I mean, you have to investigate the common things first. But generally important to try to give volume before pressors if you can determine with these measures that they will benefit from volume. Usually post-operatively low blood pressure can either be from sepsis that was brewing or blood loss, depending upon how much blood loss there was. But again, you got to monitor all these factors before you decide. I mean, that's what I've learned actually with this lecture is fluids is not always the safest thing to do for.
Yeah, from a vascular surgery standpoint, if one does an aortic bifemoral bypass or triple surgery open, and there's a significant amount of blood loss, and they're hypertensive in the ICU, you need a full stop. It makes good sense
to give
Yeah,
blood.
you can, yeah, we blood first.
Blood.
Obviously, you want to get the blood.
Yes.
CBC, stat,
Yes.
if you can. But if they're really going downhill fast, I think blood should be considered just that major surgery.
Yes.
Then you can catch up to the back end.
Yes.
And do all the parameters, because the knee-jerk reaction we see when patients go to CCU, ICU, is just
Pressors.
give pressors.
Yeah.
And sometimes that's probably when they need all you get in pressors.
Yes, it's counteracts.
So, and what's very recently, I guess, in the news, allow me to talk, some lady drank too much water and died. I guess, what's your comment on that?
Too much water?
Yeah, she
Yeah.
elderly lady, mother of 4.
Yes.
3, and maybe this, I don't know if she exercised or not, but just came back and drank a glass of water, and within a few minutes she had it.
So most likely it was acute hyponatremia. This is the classic case we used to observe in marathon runners, for example, where they're constantly running, which stimulates ADH, antidiuretic hormone, so their body is ready to take on fluid. And along the way, they would give runners little cups of water. So they're constantly taking in water, diluting sodium, and at the finish line, they would pass out and die, which is one of the reasons they came up with Powerade and Gatorade and electrolyte-rich fluids. So similarly with a woman like that, especially if she was on diuretics like hydrochlorothiazide, which puts little old ladies at risk for hyponatremia, if you imbibe too much and become polydipsic, you can induce severe acute hyponatremia and die. So I would guess that's what happened to her, if I had to guess.
Very good. Thank you so much.
Thank you so much for having me.
Hope to see you again next year.
Yes.
All right.
Thank you, sir.
Appreciate it. It's okay. Hello. We'll continue the discussions here with our next speaker, Dr. Geoffery Shook. He's a foot and ankle surgeon with vast experience in the United States, outside the United States. He's currently at the Cleveland Clinic, and we are here to see what he has to present to us on the important topic reference he's indicated. So we would sit back, relax, and enjoy Dr. Shook's talk. Thank you so much.
Can you hear me?
Yes, we
Dr.
can.
Shook.
How do I share? Okay, I got it. Do you have the screen?
Yep,
Yeah.
now we do.
Okay. Okay, I'd like to thank Dr. Oye for inviting me again to speak. I've been very fortunate in my career to be able to practice in different environments. I've been practiced in Pakistan for 6 months, rural West Virginia, rural Ohio. I just got back from Abu Dhabi, the Cleveland Clinic there, and now I'm at the Cleveland Clinic in Cleveland main campus. And so I hope through these adventures of mine in practice, I'll be able to give you some insight as to how it has affected my approach to limb salvage. And probably one of the most important things that I don't have to reiterate to everyone in the audience is the prevalence of diabetes. In the Middle East, most of the GCC countries have a prevalence of over 20%, and that's just going to continue to go up as time goes by. And because of that, we see more diabetic foot ulcers, more diabetic foot infections, subsequently amputations, and then we worry about 5-year survival rates. And ultimately, at the other end of the problem, we have to worry about healthcare costs, because these patients, while we do everything we can to help them, it is very expensive on the healthcare end. And so what we want to try to do is prevent this from the diabetic prevalence and the development of diabetic foot ulcers and infections. That's the ultimate goal. But right now, we're struggling to do that, and we're trying to basically perfect our techniques so patients don't end up with amputations after they get ulcers and infections. And so there's a lot of challenges when it comes to limb salvage, and probably the biggest is there's just so many issues to deal with: diabetes, vascular disease, renal disease, infection, and lots of different things that we need to think about to take care of these patients. And at the end of the day, what we want to try to do, just like in other facets of medicine, we have a trauma system which was developed in the United States in the mid part of last century. We talk about ACS patients and door to cath lab times. and now we have PERT teams in most big hospitals. We have to develop that kind of concept with these diabetic foot infections and diabetic problems. And we really need to develop a limb salvage process or program or team that responds almost in a similar fashion as an ACS patient. Because at the end of the day, just like with the heart, time is tissue with these infections. And the quicker you get to them and treat them, the less of the foot the patient is going to lose. And that's what our
Sorry
goal
to
is.
interrupt, Dr. Shook. We can only see your thank you slide at the end.
Okay.
Yep, now we can see it.
I'll just leave it like that then. Okay. Sorry.
No worries. Thank you so much.
So, oh, no. So what I'm going to do at the beginning here is I'm going to try to go through a couple of cases and how it's not easy, but it's very possible to have some type of effect on this patient demographic. So this next case is a gentleman that I saw at a hospital in West Virginia. It's about 40 miles up the road from Beckley. And it's a small 50-bed hospital with 2 ORs, a pretty busy emergency room. And this guy came in on a Thursday night. And the emergency room physician recognized that he has an infection, admitted him to medicine, and they decided to consult podiatry on Sunday. So this is 3 days after the patient got to the hospital. And this is what I saw Sunday evening when I saw the patient. So this is obviously a significant problem. There's an acute infection with already starting to get some necrosis. And we look at the bottom of the foot and the first MPJ is distended. And I talk to the patient and I tell him, you have a bad infection. You're probably going to lose your big toe. He didn't want that. He just wanted the infection treated first. And so we debrided the infection. And you can see he has a significant infection with tissue damage. And on the left-hand screen is post-op day, post-op 36 hours. On the middle is maybe another 24 hours later. You can already see a difference in the color of the tip of his toe, the distal aspect of the hallux, and certainly the tissue damage is significant, and he's going to lose his big toe. So you can see the progression from beginning to where we were treating him. He loses his big toe. We vacuum, we treat him with antibiotics, and ultimately he ends up losing his first metatarsal head. So I went to the emergency room physician. I went to the medical doctor and I said, look, I'm on call. If this comes into the emergency room, while it's clearly a medical admission, please call me because I want to see the patient right away. Because oftentimes these infections can be lessened if we treat them quicker than 48 hours or 72 hours down the road. So literally 2 weeks later, almost the same type of patient. This is a 44-year-old that's had insulin-requiring diabetes for over 20 years. Unfortunately, he's an IV drug user. He's right-handed. It's his left foot. He came in a week prior to this with a red-hot swollen first MPJ dorsal aspect of his foot and was given the diagnosis of gout. Came back a week later with this. So unlike the first case that you saw, the ER doctor admitted the patient to medicine, kept the patient in the emergency room, called me. I came up and saw the patient, and within 3 hours, we had the patient on the in the OR. We cleaned the wound up, took all the bad tissue out, cultured it, treated him with local wound care, and then subsequently took him back to the OR after getting an MRI because there was concern about an infection in the first MPJ. We opened up the first MPJ that you can see on the left-hand side of the screen, cleaned it out, closed it, and did standard wound care. Ultimately, on the right-hand side of the screen, we put something, a synthetic skin material called Integra over the foot, and we managed this for 3 or 4 weeks. And ultimately, we put a split-thickness skin graft on the left-hand side. The graft doesn't look great, but this is his foot 6 months after he came to the emergency room. So this is a tremendous difference compared to the first case that you saw. And the biggest difference or take home is that infection comes first and you need to get rid of the infection as soon as possible. And simply by alerting people that can take care of this as soon as possible will oftentimes mitigate the problems that we see from diabetic foot infections. So beginning, end. So the cornerstones of taking care of diabetic foot infections or limb salvage challenges really boils down to like 3 or 4 things that are extremely important. Infection that I just mentioned, revascularization, the function of the foot, how it works, the biomechanics of every foot, and then patients that have neuropathy as well with all these things. And then certainly you always want to worry about diabetic control and nutrition and other things, but these are the main prioritized things that I look at. And certainly an acute infection is 1, and revascularization or vascular status is 1A. These are the 2 most important things that you have to assess and address as quickly as you can. So here's another case, and so I'm going to try to mix this up a little bit. This is a patient from Islamabad, and he had completed the Hajj, got back from Mecca, and this was about beginning of October, like October the 4th or 5th. And I know this because it was a week before my birthday. And so he went to see his primary care doc, who started him on Keflex a week before this picture. He wasn't getting any better. He was referred to me, and I admitted him to the hospital and got labs, and this is kind of some of the stuff we saw. And so obviously this guy has a very bad infection, and it's an operative infection. And this is the foot immediately before we do surgery. And so this is the first debridement, like 2 days afterwards. And the bottom looks better, but the top I'm not so happy with. The debridement wasn't aggressive enough. Post-op day 5 on the left, post-op day 7, and then we take him back to surgery, clean him up again, take more of the bad tissue. And intraoperative surgery 3, we know that he has a septic joint. We take the metatarsal head out, clean the soft tissue up again. And many of these patients need multiple debridements for a number of reasons. One, in this gentleman, I wanted to try to save as much of his foot as possible. I didn't want to take off any of his toes to start off with. And 2, the infection sometimes is not controlled as we would like the first time around, and we need a 2nd or 3rd debridement to get the infection under control. That's not ideal, but it happens, and you need to recognize it when it does happen. So we took the metatarsal head out, we debride him again, we keep the 2nd toe, so we may need some of the skin from the 2nd toe. And we take him back again, and we irrigate it. We do a delayed primary closure on the bottom. We leave the wound on the top open. Now, this gentleman is primarily an infection problem. He had palpable pulses, good bleeding tissue, and so he was not a vascular issue. Then he went on to chronic wound care, and I saw this guy every 2nd or 3rd day, cleaned up the wound dorsally and plantarly, and you can see the progression. As weeks go by, the wound's getting better, and ultimately we get the bottom and the top completely granular. And this is what the guy looks like 30 months after a split thickness skin graft. So we saved a lot of the foot. He's infection free. And if you just take a glance at the foot, you don't really notice that the 2nd toe is missing. And so I think if you approach these patients in this kind of fashion, that you have a chance to get this kind of result. It doesn't always end up like this, but this is what we want. Kind of the whole process with this guy from beginning to end, from the bottom and the top. And so the first part of this is infection. And then, like I said, infection is 1A, acute suppurative infection, and then that's number 1. And then 1A is clearly revascularization. And I think, Dr. Oye can comment on this, but one of the things that's really surprising to me here in the United States still is the number of patients that have amputations, specifically major amputations, and don't even get any attempt at endovascular or surgical revascularization prior to having that amputation. And there's another study that I didn't put in here. There's a high percentage of patients that don't even get an angiogram as well. So I think that we have to really be aware of this, and patients that have wounds that don't have pulses need to be seen by a vascular specialist, need vascular investigation so that we can try to eliminate or minimize the patients that get major amputations. So here's a gentleman that I saw, same hospital that we talked about before, the first couple of patients, and he came in with this problem. On the left-hand side is my initial time to see the patient. The second picture over is about 48 hours later. You can see The tissue damage is starting to increase. The discoloration is increasing. The patient is developing a white count. And so I call the vascular people in Charleston, West Virginia. We get them set up to go there. And I go ahead and I take the toe off, kind of do source control, get the infection under control. The picture third over from the left is a day after the debridement. The final picture is 2 days after the patient had restoration of 2 of his vessels endovascularly. And so you can see the quality of the tissue around the periphery of the wound is definitely better. And this patient ended up healing by secondary intention. We took his metatarsal head out and closed the wound partially. He would have been better to have a transmetatarsal amputation, but just had too many medical problems, renal disease, liver disease. He was on a vest. His ejection fraction was less than 20. And so we didn't want to subject him to any significant surgery. We treated it conservatively, and we were able to get the initial wound healed, which you see on the left-hand side. But this patient develops a wound on the lateral aspect of his foot. And now we're going to this is a segue into the biomechanical part of the functional part. So this guy lost his EHL tendon. And so when he pulls his foot up, he inverts his foot, puts more pressure on the lateral side of his foot, and this is how he developed these wounds. These are not because of a vascular problem per se. It's a functional malalignment of his foot when he dorsiflexes his ankle. And so we were able to do something called a gas rock recession. We do it with local anesthetic. We weaken the muscle on the back of his leg, which decreases the need for his tibialis anterior tendon to dorsiflex the foot. We also had to take his 5th toe out, but this is what we had. This is about 20 months later. In a gentleman that's a very sick patient, we were able to get his infection under control. We were able to get him revascularized. And then biomechanically, we were able to balance his foot function out so that he did not have areas where he was predisposed to ulceration and persistent wound problems. And we'll just kind of go over that again. We'll skip this. This is a patient from Abu Dhabi that had a 5th metatarsal phalangeal joint resection for osteomyelitis. The metatarsal was resected proximally, the peroneal tendons were damaged, and so this patient had a chronic ulcer where you see it, 5th metatarsal base remnant. And so the patient was told that she needed to consider having an amputation above her leg, above her knee, below her knee, above her ankle. She has palpable pulses, and her foot looks reasonable. Tissue quality looks good. She has good color return. She's neuropathic. And so we want to try to prevent this. And this is a biomechanical problem. So we look at her x-rays, and you can see on the picture on the left-hand side, her foot turns in, and it's because her peroneal tendons have been compromised, and her tibialis posterior tendon is unopposed and pulling the foot in. We get an MRI on the patient, and the images on the top, the fat-weighted images or the T1 weighted images, here at the 5th metatarsal base, there is no marrow replacement, or there's no gray within the bone. So that tells us that most likely she does not have osteomyelitis. And the coronal images confirm that. Here's the 5th metatarsal base across the board, and there's no marrow replacement, or there's no gray within the bone. So we're pretty, not certain, but we have a good feeling about the fact that she probably doesn't have a remnant osteomyelitis, and this is a mechanical problem. So we take her back to surgery. We take the 5th metatarsal base, what's left of it, out. We weaken her tibialis posterior tendon, her deltoid ligament, so that I can take her foot and evert it or abduct it. And so there's no abnormal pull in the foot. Ultimately, we get this wound to heal up, and you can see her foot from the bottom now. The wound is healed. Her foot is a much better position, and when she stands and walks on it, she doesn't have such an uneven pressure with most of the weight going to the lateral side of her foot. It's more evenly distributed, and she has less of a chance of developing an ulcer like this again. So one last thing, we have patients with neuropathy, and these patients, and these are very much mostly diabetic patients. They develop a deformity in their foot, and it's typically in this area, in the lesser tarsal Lisfranc area. They have a prominent bone, and these patients are often told that they need to have an amputation because they have osteomyelitis. And this patient did have osteomyelitis, but we took the infected bone out, treated it appropriately, and then took the patient and reconstructed him with a fusion and a frame. and this is what he looks like down the road. So we've realigned his foot after removing the infected bone and made his foot stable and a much more functional foot without needing an amputation. So hopefully I've been able to go over some of the more salient points of limb salvage, specifically the importance of getting rid of infection when it's a surgical problem as soon as possible, understanding, evaluating, and knowing that the patient oftentimes needs to be revascularized, and then addressing some of the mechanical aspects of each patient with respect to pressure on the bottom of the foot to try to either get rid of or prevent problems with respect to further ambulation after you've addressed infection and revascularized the patient. Once again, thank you, Dr. Oye, for involving me. It's always a pleasure to work with you and speak to your group.
Thank you, Dr. Shook. Appreciate it. Nice talk. Excellent. Again, you mentioned the big keyword, adequate vascular workup and testing is essential for healing, especially for persons who do not have adequate blood flow when you do your surgery. So that's always important. There are over 200,000 amputations in the U.S. alone, and many of these persons don't even get vascular workup. So that's very good. Thank you so much. Any questions from the audience? One question from me to you would be,
Yes, sir.
For those patients who are not within the sphere, say within the United States, for example, and don't have the complement of your expertise to manage their wounds like you did, what do you use primarily for your debridement? You say you take them to surgery and do debridements multiple times sometimes. What's your go-to tool for debridement?
I'm really kind of a simple person, to be quite honest with you, in the OR. I like to use a 15 blade. I like to use Metzenbaum scissors, and I like to be aggressive. I like to, other than that case you saw where I wasn't as aggressive as I should have been, I like anything that's bad needs to come out. And I think you treat it like, neoplastic problems, cancer patients. You need to remove all the bad stuff that you can. And typically I use a 15 blade, I use Metzenbaum scissors, and I think that's pretty, very much available worldwide. Now we have debriding tools like a Masonic ultrasound debrider. There's things like that I think are very helpful, but I don't think that those are available across the board internationally like they are here in the States.
Yeah, that's correct. Yeah, what's your experience on the use of VasoJet? Have you used that much?
Yes, yeah, and I like that very much. I think a lot of times when you're dealing with deeper structures, it can give you a much more even debridement, and you can potentially avoid getting into the joint space or getting into the deep fascia if you want to avoid it. So I like that very much. But like I said, for instance, when I was in Pakistan, they did not have that, and that was 10 years ago. But when I was in Abu Dhabi, we had that, and we used it all the time, and it's a very good tool, I think.
Very good. Thank you so much, Dr. Shook. We'll look towards seeing you again next year, and same time in October, thereabout. And we do have a global ground round, so please feel free to join us in global ground rounds every 3 months. The next one is December. If you have any interesting case you want to present between now and next October, be an opportunity for you to let us know. Thank you once more.
I'd love to do it. Can my residents participate in global ground?
Absolutely. Absolutely. They're welcome to. Any interesting case they feel will be of benefit to the audience, both within the United States and outside. It's a means for us to share our experiences.
Count on me. We'll be there. Thank you very much.
All right. Thank you. Appreciate it. Okay. At this point, if you can get off your screen, Dr. Shook. Okay, good. Thank you. I would bring that back Dr. Dawn Olson, who is, as I said before, consultant endovascular vascular surgeon in Arizona, and she will be presenting to us today on the science topic. She would be letting us know in a few minutes.
Dr. Olson, are you there?
Yes, I am. Hang on. Let's see what we can do here.
Okay, thank you.
I'm using my partner's computer, so I need his password, unfortunately. Here he comes. All right, Julio. Can you, or you use your finger to open it up? Julio's here. He's next to me. Yeah.
Hi,
He had
Julio,
to-
how are
he had
you?
to either use his finger or his, his cornea. Something to get us in here.
Julio, how you doing?
I'm doing fine. How you doing, guys?
Very well. Thank you.
Good, good.
All right, let's see. Let's try this again. All right, tell me you see something.
Yes, we see it.
Oh, thank goodness. All right. Hang on. I'm trying to just get it as one slide, but it's not doing it for me. So just a sec. Okay. All right.
Perfect.
All right. So, so you can hear me now? Everything's hunky-dory?
Yep, everything's great.
Perfect. All right. So this was actually a little craziness. I've been out of the country and I had agreed to participate. And then the initial presentation I couldn't get the videos to play. And my partner, Dr. Rodriguez, was kind enough to let me use one of his presentations on some of the stuff that we've been doing out here in Arizona. So this is a presentation about the best management of more complicated thoracic aortic dissections. So standard treatment for type A dissections has been interposition grafts, open emergent surgery for these patients in order to address the ascending aorta. Now, when we look at the classification, the type A, the DeBakey 2, you see that involves the ascending alone. So again, typically it is managed with an interposition graft alone, and the patient would do well with that type of repair. So here you see with the Stanford B, DeBakey 3 dissection, where it extends from the left subclavian down. Typically, we have managed that with endografts. And that has been, at least for the last couple of decades, that endografts have become the primary treatment for type B dissections. So the concern is, what do we do for those patients that have extensive dissection, not only involving the ascending aorta, but also the descending aorta? And do we have something better that we can offer these patients to help limit their return to us later in years? So again, for the type A dissection, traditionally an interposition graft is placed, and we leave the remaining aorta untreated. Those patients tend to come back years later with aneurysmal dilatation of the false lumen, or chronic pain, or further extension of the dissection, maybe following a hypertensive crisis, or malperfusion, just because of how the anatomy starts to change over time and the true lumen becomes more compressed. So we have an experience where we had managed type B dissections with good success. So this publication of ours was in 2008. It included 106 patients. It was almost equally divided, that there were acute patients that included about 56%, and the remaining were chronic dissections. With these patients, we assessed we called it a true lumen index and a false lumen index. And that's where we measured the caliber of these areas, both at the proximal aorta, the mid aorta, and the distal descending thoracic aorta. And we found patients who had been treated covering the entry tear had a tendency to do well and had remodeling of the aorta. So there was less of that progression of disease with aneurysmal dilatation and what have you. So again, when you covered the entry site effectively, it dampened the flow to the false lumen, expanded the true lumen. And in cases where the dissection had only extended to the level of the celiac, often that false lumen completely resolved and the true lumen expanded. And then in others, there was decreased retrograde flow from below. So Again, that was success covering the entry tear, but these patients who have the type B dissection that extend into the infrarenal aorta will always have some degree of retrograde flow and need to be followed. And, you know, there's different ways the standard criteria for documenting endoleak maybe doesn't necessarily apply to these type of patients. You will see them called type 1B endoleaks, but they will always have that endoleak unless the abdominal aorta is managed as well. So the key is to limit the retrograde flow if possible. So when we look at the arch aorta, again, patients presenting with a type A dissection, the type A is managed with the interposition graft, but then with the arch involvement, often it is left alone until they return later for follow-up. And those patients typically, we have done extra anatomical bypasses with carotid bypass and carotid subclavian bypass, or carotid subclavian bypass alone. So for the group that has the extensive dissection, they're kind of left in limbo for several years unless we can do things that we can maybe preemptively manage as we go along with these patients early in their course and hopefully prevent some of the problems down the line. So again, they have the interposition graft in the ascending, then possibly innominate bypassing, otherwise carotid or carotid subclavian bypassing, and then endograft to the descending thoracic aorta. So at our institution, we've been working as a team with the cardiac surgeons to try to develop better ways to manage these patients. So in hopes, we ask them, instead of just doing an interposition graft at the time of the procedure, if it's possible that they can do a debranching. Obviously, these patients come critically ill and they go to the OR emergently, but that has been helpful, even if they bypass the innominate alone. The other thing that has occurred is that there is a device available called ThoroughFlex, which is an endograft, a short endograft that is deployed via open approach from the ascending aorta just into the descending aorta, or from the arch into the descending aorta. And that leaves you kind of a landing zone to go back and you can address things later. And you can come back and do those bypasses, carotid bypass or extra anatomical bypass if need be. So if you look at this device, again, it has the option of debranching at that time, even to the different arch vessels. It has the option for perfusion when they go on bypass. And again, this is the portion that is the endograft, and it's a short endograft, again, positioned in the proximal descending thoracic aorta that gives you a target to land for, and then maybe come back later to address the arch branches if they're not addressed at the time of the procedure, the initial aortic procedure, ascending aortic procedure. So here you see this device kind of large in caliber. You see the surgeon positioning it within the arch aorta and then holding steady, and you'll see the pull back to deploy a pin and pull kind of technique. But you see, he has to keep some strength on that resistance on that main device, and that is simply how it is done. Some cardiac surgeons at that time attempt to fenestrate from within the aorta into the carotid or subclavian, but otherwise they leave that for us at another date. So, you know, obviously there are multiple endografts available on the market to treat thoracic aortas, including the Gore endograft, Terumo, Cook. So what we did here is we took each of those endografts and assessed how we could work with laser fenestration if we plan to fenestrate these grafts for the descending thoracic aorta, I'm sorry, the arch aorta. So here you see at the left, using the laser catheter, we would abut it against that area, and we assessed all three of those grafts. So the one that was more challenging was the Gore graft, because, you know, they have this piece of material that is on the outer curve. So you would have to go through not only that, but the graft itself. So that was more challenging. When we did the Cook graft, which is this one here in the center of the screen, It penetrated fine, but the edges of the fenestration were not smooth, a little hair-like pieces you could feel around that. And then when we went to the Terumo graft, that one actually, it kind of melded and melted in that area, and it was a very smooth transition across the fenestration. So in the few cases that we have done in the thoracic aorta, we have used the Terumo graft, and we also have done some abdominal fenestrations, which I'm really not going to talk about, but that also was with the Terumo graft, just simply because of this technique that we saw when we attempted to laser. So here in these images, you see this patient has the repair proximally, and then you have the thoroflex graft there, and then coming from the brachial artery to proceed with fenestration from the left brachial artery into the subclavian artery, and then applying an endograft. So this is a patient who is 70 years old, who had presented urgently with an ascending aortic dissection, zone 0. He underwent interposition graft repair in 2020, and he returned in 2021 with aneurysmal degeneration of the descending thoracic aorta with the aneurysm up to 6 centimeters. So again, he had that interposition graft placed. He had the dissection that extended into the infrarenal aorta, but now the concern of significant dilatation within just a year of his initial surgery. So the plan was for an arch fenestration of all 3 vessels for this patient. So what we had discussed, if you see his images here with this CTA as it's playing, you can see the dissection and the aneurysmal dilatation in the proximal area. You see that the flow in the false lumen extends all the way up to the arch. So that's probably what was giving him more of his symptoms as well. The plan would be for brain perfusion to establish that, and then deploy the endograft, and then proceed with fenestration and placement of covered stents. So here is our schematic drawing. The interposition graft is in place. You have the 3 arch vessels. We measured from the CT what endografts we would need. So we had that plan, and then our plan to use the perfusionist for the brain perfusion. So what we cannulated the right subclavian artery and the right femoral vein to establish the perfusion, and then proceeded with retrograde cannulation of the left common carotid artery as well as left subclavian artery once the endograft was deployed. Okay, so here, again, the brain perfusion has been established. We selected our endograft. The endograft is in place, covering all 3 arch vessels. So next, we used a steerable catheter, again, coming from the left common carotid artery first, cannulating the common carotid artery, and then advancing we typically use a Destino catheter in these approaches, advancing then a laser probe that was 2.0 millimeters. We would abut that laser probe against the endograft. You want to have good resistance against it so you can feel that you're pressing against it. You want to verify your position not only in the AP view, but you're going to go oblique, left anterior oblique, because you want to be kind of on top of that endograft, and you don't want to be sliding down the side of the endograft. So that's helpful. Again, the fact that you are in the actual artery is good too, because you're pushing against the endograft from that point. Once you verify it, then you begin your laser. And when you use your laser, you keep resistance on it, and then it'll pop through. When it pops through, you already have your wire sitting in that laser catheter. You advance it across that lumen, maintain that position. You can advance the sheath into that area just slightly, so that you maintain your position. You take a picture to confirming it. And with that, you go ahead and balloon that area with a smaller caliber balloon, maybe a 4 millimeter balloon. And then you go ahead and deploy whatever size stent you chose to be appropriate. So maybe oversizing 10%, 20% at most, either using an ICAS stent, Gore VBX. Those have been the primarily 2 ones that we use, the balloon expandable, but you could also use Viabond. So here at these images, you see left common carotid done or left carotid first done, stenting the left common carotid, then the left subclavian, then the innominate from the left carotid approach, or from the and then the entire time maintaining your cerebral perfusion from the perfusionist. So there is your completion angiogram. That is a schematic at the side demonstrating what size devices we chose. We chose a 34 and then more distally a 36. And then here at 1 month, we have some imaging here that shows the patency of the endograft. And you see that you must place your stents within the endograft itself so that there's at least a few millimeters in, or else you'll lose access and have an endo leak. And then when we have 6-month follow-up, here you see the patient has improvement. There is decreased flow into the false lumen. There is still some retrograde flow, and this is at 6 months. It's smaller. The false lumen retrograde flow still extends up to at least mid-chest. See, there's something still there. And then when we go to the 12-month follow-up, however, the retrograde flow has decreased considerably. And you see here in the CTA that the false lumen is mostly thrombosed, the extent of the endograft, and only at the very distal endograft do you start to see it. And that area is not covered below this area. So I think good success with that. No pain for the patient. The aneurysmal dilatation has decreased in caliber with that false lumen. And again, retrograde flow significantly decreased. So in conclusion, we believe it takes a team effort to approach the more complicated type A, type B dissections. And the standard interposition graft, of course, still is what is appropriate, but if there's the possibility of an innominate debranching, that can be helpful for later intervention, as well as the possibility of deployment of that short endograft for later intervention. Otherwise, we can always come back later with our own endograft and fenestrated grafts. This can be done postoperatively once the patient has recovered to prevent the progression of aneurysmal disease, malperfusion, or further extension. This technique can be applied to the abdominal aorta with the visceral branches and renal arteries. It's a little different and more challenging in that obviously you cannot cannulate the renal arteries and go retrograde and abut against the graft or the SMA or celiac without opening the belly. And so other techniques can be used for the visceral branches, such as pre-deployment of a stent, and then placing your endograft and then fenestrating through that endograft into those visceral branches. I just want to mention, just recently in the US, Gore has received approval for a fenestrated endograft. We have yet to put it in place and use it here, but it has a single fenestration right now for the subclavian, but you can, I think you can modify it for a carotid as well. But these, again, we haven't used it, and they do have strict criteria right now as to which patients and the measurements and diameters that are necessary for landing zones for that as well. Thank you.
Thank you, Dawn. Nice talk. Appreciate the information Desmond had given us today. Any questions? Any questions from the audience? No. What's the cost of your different grafts that you use for the descending?
The cost?
Yeah, the short piece graft that you for the ascending.
That short piece, I don't know how much that costs. I would think most of the endografts here cost probably like $10,000, honestly.
Now, the short piece that you applied, I see the surgeon had one hand fixed and as the pin and pull.
Right.
I hope that was under fluoroscopy and the hands were done under fluoroscopy, right?
You know, I don't know that they do that under fluoroscopy, you know, because it's open and right there, honestly.
Yeah, I see.
Yeah.
Okay.
So it's just to seal the that tack it down at that one area, and then they can sew that graft. So
it looks pretty neat.
Yeah.
Thank you so much, Don. And hopefully we'll see you in our grand rounds in December if you can, if you have any interesting cases.
All right, thanks for being patient.
There's one question for you from the global audience. Hold on.
Sure.
Dr. Gupta, read to you. Hold on.
Hi, Dr.
Sure.
Olson. So the question is, any side effects to consider or concerns about the graft?
I'm not sure, but I don't think so. You mean the thoracic endografts that we're using?
Yeah.
Okay, I don't think so. We've been using the endografts for years. Obviously, with the new thing with fenestration, there's a couple of things that are as a concern that if you're creating your own fenestration, one is that you could have potential endo leak, a type 3 endo leak from the branches. The other thing is if you don't expand that fenestration with a balloon ahead of time, you can have crimping of that endograft that you then put in. And so then you may have to come back later, and you don't, maybe coming from the brachial is not such a big thing, but sticking the person's neck, maybe they won't necessarily love that, and we're not necessarily cutting down to do that, but that could always be a compromise of the flow. So definitely have to balloon, definitely have to advance the covered stent within the endograft adequately. And then probably the biggest concern is that you could, if your fenestration is not accurate, meaning relatively center on the curve, the outer curve of that endograft, and you slip down the side and then you lose access, you have basically a rupture or a bleed there, and you have to seal that with another endograft before you proceed. And that we see more common in the abdominal aorta if you're doing the fenestration there, because what we often do there, again, we can pre-stent the renal arteries, let's say if that's what we're going to cover, place the endograft, so you are covering those renal arteries now, and then you use your imaging, the same imaging that you use to initially deploy those stents, you use that to position your catheter and fenestration graft to go through. But if it is not in the correct position, and you push through and then you take your picture and you see a stravization, now you have a perforation in the aorta. And so if you can't correct that, then you end up putting another endograft inside to solve that rupture. So
Yep. And then a follow-up question was, how long does the graft last?
the grafts have been used for years, and so I think the grafts last indefinitely. We don't see these grafts having issues as far as deteriorating, but with the known pathology of dissection and how it becomes aneurysmal and can change over time, all of these patients have to be followed routinely with initially CTs, probably at 3 months, 6 months, and then yearly, unless there's concern for changes. And we haven't seen like separation of the grafts. That we did see that with one of the grafts in the abdominal aorta, but the company corrected that problem. So most of these grafts we see lasting indefinitely.
Thank you.
It's the anatomy more so. Thank you.
Thank you, Don. Do you have any favorite stent graft that you use at this time?
Right now, we've been using the Terumo mostly, just because of that fact. When we did the fenestration on back table, just to assess each of the grafts, the Terumo, when we went through it, it just sealed nicely along the edges and didn't have fraying, whereas the other one had fraying. And then on the gore, the issue was that outer little like cellophane, I don't know the name for it right this second, that sits on the outer curve. So you would have to fenestrate both of those pieces to go through. So Terumo is what we've been using right now.
You have a favorite covered stent?
A covered stent, it depends on the length, but and the caliber. VBX is helpful when you have to go bigger, because VBX you can deploy through smaller size sheaths and still balloon expand it to make it a larger caliber. So I think that's beneficial. That's what I would say for that one.
Very good. Thank you, Don. Hopefully we'll see you next year. And say hello to Julio. Thank you so much for letting us be part of your talk today. Thank you so much.
Thank you.
All right.
Hang on.
All right. Thank you so much. And at this point, we'll have a lunch break. And please feel free to devour some food supplied to us today by our wonderful associate company here, the Shockwave Medical. And we thank them for being here. Thank you.
Thank you. And we will reconvene for the rest of the presentations at 1:15 EST. Thank you.
Amy is having something go on with her machine, stating that there's a temperature problem, but she rebooted it and hasn't had the same problem.
What machine?
You just shut it down.
Okay, machine.
Shut it down.
Yeah, shut it down.
Hold on just 1 second, Justin.
I can't find my cursor to do that. Is there any? Okay, stop sharing. Thank you.
Okay. Sorry about that. I'm getting pulled in.
Yep.
Okay, welcome back, everybody. We'll get started on the afternoon session. Our next speaker would be no other than a venerable coordinator of our conference this year, Dr. Gupta. She has been a very vital person in making sure this conference was successful. She would be presenting to us on the rescue of AV fistula in office-based lab, and we look forward to the talk. Dr. Gupta.
Thank you, Dr. Oye, and everyone here participating. And I will get started. I am Dr. Yati Gupta, recent medical graduate, and I'm here to talk about the rescue of a failing AV fistula in an office-based lab. So I'm going to share my screen and we can get started. All right, perfect, it is sharing. All right, so thank you for coming to my talk, and thank you for everyone who is signed in to hear all the presentations today. So again, my talk is on the rescue of a failing AV fistula in the office-based lab. So let's start. What is an office-based lab? I had the honor to do my surgical rotation with Dr. Oye, where he had an outpatient procedure room, which helped all the people around the Appalachian area get the care they need. So an office-based lab, as I said, in an outpatient setting, the procedures are done under local anesthetic, and different procedures that can be completed in the office-based lab include an arteriogram, a venogram, aortogram, phlebectomy, a shunt study, balloon angioplasty, AVF rescue, which is what my talk is on, AV graft repair, and stenting. What are the benefits of an OBL? Well, firstly, it does decrease the financial burden in underserved areas. They don't have to get admitted to the hospital or go to a traditional operating room if their case allows, which can decrease their financial burden. There's a faster recovery time as they are we're using local anesthetic here versus being put under anesthesia. There's an improved efficiency of care, and it helps increase access to care in underserved communities, which again is the topic of the conference, bringing awareness and access to care in rural communities. So an AV fistula is a connection made between an artery and a vein for dialysis access. This is used in patients with end-stage renal disease to receive their dialysis. Access is created and matures over a 2-month period, and while maturing, venous catheter is used for patients who need to start dialysis right away. Regular veins would collapse under that repeated pressure for regular dialysis, so that's why it's important to create an AV fistula. I'm just going to put the volume up because I think some people are having trouble hearing. Oh, it's all good now. Thank you, Dr. Michelle. All right, so about 500,000 people require hemodialysis, with approximately 100,000 new cases of end-stage renal disease yearly in the US. So when the fistula is created, the maturation takes about 4 to 6 weeks after construction, and then a nephrologist, based on how the fistula looks, will decide if it is safe to be used for dialysis. Why do we recommend an AV fistula? Well, they last longer compared to other types of access. It provides good blood flow for dialysis, and it's less likely to get infected or cause blood clots. The ideal dialysis fistula delivers a high flow rate sufficient for effective dialysis. It's suitable for repeated cannulation and has long-term patency rates with minimal complication. But why are some reasons an AV fistula will fail? It could be stenosed, clots can occur, infections, any accessory veins can disrupt the flow, or pseudoaneurysms can also disrupt the access. How does a failed AV fistula manifest? So when you palpate it, you'll feel a weak or absent thrill. There will be high venous pressure during or before hemodialysis, and post-hemodialysis, there could be excessive bleeding. In addition, there can be swelling, redness, warmth, skin changes, which include bulging, bleeding, and peeling, and a Steele syndrome. So the volume and rate of blood flow can decrease, and that you may be unable to dialyze adequately. All right. So what are some treatment options if the AV fistula fails? There are medications, angioplasty with or without stenting, thrombectomy, surgical revision of the failed AV fistula, or surgical creation of a whole new AV fistula. The sooner it gets treated, the better the outcome and chances to not have to create a new fistula and wait for the whole process of maturation again. So if you see any abnormal changes, just get that checked ASAP so they don't have to go through that whole process again, which is, hard for the patient. So just in this clinic here in Beckley, West Virginia, during 2019 to 2022, there was a number of office-based cases that were successfully done. 24 using the cephalic vein, 22 with a basilic vein, 8 with the axillary, and 20 with the subclavian vein, and more to come. So patients here were referred from hemodialysis centers following a malfunction of their AV fistula performance during hemodialysis. The patients who are seen in the clinic usually range from age 22 to 92 years old. Venous ultrasounds and venograms were performed to interrogate the AVF axis, and the venograms were performed in a retrograde and anterograde direction to identify the culprit lesions. Angioplasty and or stenting of target lesions were undertaken with appropriate sized semi-compliant or non-compliant balloons. So the anterograde means the arterial needle is pointing in the direction of the blood flow, whereas the retrograde venogram is when the arterial needle is pointing towards the arterial anastomosis. Angioplasty and or stenting of target lesions were undertaken with appropriate size semi-compliant or non-compliant balloons. Bare metal or cover stents were selected for treatment of lesions with significant recoil post-angioplasty greater than 30%. So our first case is an AV fistula rescue of the basilic vein. We have a 75-year-old male who presents to the clinic for an AV fistula study. He was sent over by the dialysis center due to trouble getting access. At the time of his appointment in our clinic, there was no pain associated with the fistula. Allergies are listed. He has a past medical history of hypertension, lung cancer, GERD, gout, benign prostatic hyperplasia, and renal failure. His list of medications are here, and his past surgical history include a left arm brachiobasilic AV fistula placement, left arm AV fistula procedure, tonsillectomy, and removal of his top left lung and upper right lung. So pre-op, his diagnosis was end-stage renal disease with a malfunction of the AV fistula, and the procedure completed was a left basilic vein AV fistula angioplasty with a 7 by 40 millimeter Dorado. The findings upon imaging was tortuosity of the AVF, therefore we considered a large stent and a larger angioplasty. So the details of the procedure, of course, informed consent was obtained, and we placed the microvenous sheath. Contrast was inserted to demonstrate flow through the left arm basilic vein with patent long indwelling stents. The axillary and subclavian veins were patent, and the basilic vein proximally had a 4-centimeter segment of a V-shaped tortuosity. This was followed by placement of a 0.035-inch guide wire where we advanced the 7 by 40 millimeter balloon to the target area. The angioplasty was performed to 12 atmospheres in 3 minutes. And the completion, which I'll show you on the next slide, showed improvement. And treatment options will be either angioplasty with larger stents to the area of the V-shaped stenosis or end-to-end anastomosis of the vein following complete transection. So we applied 5-0-proline, benzoin, 4x4s, and tape to cover it all up. Post-procedure instructions, the fistula had been rescued to avoid any further complications, but needed to be rested until a larger stent or end-to-end anastomosis by the vein would be done. So complications here were prevented by rescuing the vein before any kinks got worse. And here you can see the restoration of the flow. Our next case is a cephalic vein rescue case. A 74-year-old female sent from dialysis due to inability to access flow from her cephalic AV fistula. This patient is experiencing pain in the area, which she described as burning and rated it as a 7 out of 10. Additionally, her last few dialysis treatments, she was experiencing her blood pressure dropping and instances of clotting. The patient had a permacath, which dialysis center recommended to remove, but until her AV fistula was evaluated, she did not want to get it removed. Her allergies are listed. Her past medical history includes chronic kidney disease stage 4, diabetes type 2, hyperlipidemia, gout, osteoarthritis, vitamin D deficiency, nephrotic syndrome, and hypertension. Her medications are listed below, and her past surgical history includes kidney endoscopy for calculus removal, AV fistula creation, and a hysterectomy. So pre-op, her diagnosis was malfunctioning AV fistula of the left arm and end-stage renal disease. So for the procedure, we did an AV fistula venogram of cephalic vein of the left arm, a balloon angioplasty of the mid-cephalic vein with a 6x60 millimeter Cook balloon, and ligation of 3 prominent cephalic vein branches to augment the maturation of the AV fistula. The procedure note is here where the flow there was flow through the cephalic vein. It demonstrated a mid-cephalic vein area of a web-like stenosis, 3 prominent cephalic vein branches that were stealing flow from the main vein. These branches were identified using venogram, and the areas were marked with surgical marker. We used 1% lidocaine, the local anesthetic, which again helped avoid them going under unconscious anesthesia. And the target area was infiltrated. A 3-centimeter lesion was made with a scalpel to expose the varicosities, and these were captured with hemostats tied with 4-0 silk. The patient tolerated the procedure. The venogram was revealed successful ligation of all 3 branches. So the microvenous sheath was then upsized to a standard forefront sheath over a 0.05 35-inch guide wire, and we proceeded to cross the stenosis with a 0.018-inch guide wire. The balloon angioplasty was then performed with a 6x60 millimeter 18 LP balloon with marked improvement of the stenotic area. Then a stronger AV fistula thrill was noted post-op compared to the weak AV fistula pre-op. Incisions were treated with the vicryl sutures, proline, and digital pressure was applied for 5 minutes. And again, we covered it up with benzoin, 4x4, acrylics, and ACE wraps. So here you see the changes in the flow based on the fistula rescue, and the prominent branches were then closed, and the main cephalic vein had successful flow, and the thrill was palpable. So follow-up after an AV fistula rescue. You got to keep the area covered with 4x4 acrylics and ACE bandage for 24 hours. Dressings may be removed 24 hours after procedure, and you want to keep that hemodialysis insertion site clean and dry. And in 7 to 10 days, follow up for removal of the sutures. So end-stage renal disease and the need for hemodialysis is highly dependent on a properly functioning AV fistula. Early recognition of the AV fistula malfunction and appropriate rescue intervention can prevent thrombosis requiring open surgical therapy. Endovascular intervention can be easily performed in the endovascular suite or cath lab to prevent more expensive operating room procedures. Revascularization with early recognition and referral, patients are able to leave the angio suite cath lab within 10 to 15 minutes post-procedure because only local catheters and very minimal local sedation is used. So approximately 430,000 patients in the US are dependent on hemodialysis, and options include catheters, AV grafts, or AV fistulas. So my conclusion is the early recognition and referral of a malfunctioning AV fistula can lead to successful rescue with minimal effort. Early discharge from the angio suite without disruptions of the patient lifestyle remains attractive and promising. The minimal sedation allows for minimal anesthesia-related risks. Immediate use of AV fistula can therefore prevent implantations of tunneled or tunneled catheters. Thank you.
Very good.
Any questions?
Yes.
Thank you, Dr. Edwards. Very informative presentation. When can we use the AV fistula after this for dialysis? What's the period of time? Can we use it immediately or
You can use it immediately, or you could use it the next day.
Yeah.
If they're not scheduled to have dialysis that day, if it's safe, and if they don't have a catheter already for dialysis already, and it just alone, you can use it the next day. Be safe. But if they have no access, and that's all access they have, you can use it. Yeah. All right. So that was very informative, Dr. Gupta. One of the things that we think it's useful with this technique is the fact that, like you mentioned, patients go home really quickly within 15 minutes of the surgery, because no major sedation was used, and most times you can really pretty much go home and get dialysis next day. So that's the benefit of it. And more importantly, you identifying the problem sooner and preventing complete thrombosis of the graft, which will require them to have a much more invasive intervention, i.e. embolectomy and all that. Nowadays, we do have percutaneous way of creating AV fistulas, which also can be done in the OBL setting. So we have a couple of companies that have percutaneous devices, so no cuts involved. You can stick a needle wire into the vein and artery and then connect it. So that's also something that could be available for use. So again, the OBL option is a great option. Will be a great option in the context of the African context, as well as the rural areas where you may not have a surgeon to. You want to minimize the need for big surgery. You can do this in a minimally cost prohibitive way. So that's a great way to do that. So expanding the OBL concept to PAD, expanding the OBL concept to dialysis patients and others is one of the take-home messages for this conference. Thank you so much, Dr. Gupta.
Thank you.
All right. All right, thank you very much. Our next speaker comes to us from Georgia, USA, and he's an interventional cardiologist consultant, and has been doing this for a while. He graciously wants to give us a talk today again on evaluation of chest pain, and our speaker is no other than Dr.Obinnaya Emerole. Is welcome, Dr. Emerole, welcome to the podium, and thank you for helping us out with the conference this year.
Thank you very much for inviting me, Dr. Oye. It's really a pleasure. Good afternoon to my colleagues in the US, and good evening to those in Nigeria. Today we'll be talking about chest pain. As you all know, chest pain is something that's very common in clinical practice. It accounts for about 1% of the visits to the physician in the outpatient setting, and about 5% of the visits in the emergency room. We use the term to describe not just chest pain, but pressure, any uncomfortable or unpleasant sensation could be located in the anterior chest wall, the shoulders, the back, arms, jaw, upper abdomen. Other equivalents of angina include shortness of breath, nausea, fatigue, numbness. Basically, any symptoms that we would think represent ischemic pain, suggestive of, that will give us a suspicion of obstructive coronary artery disease. And it's important because the differentials range from benign conditions to life-threatening conditions. In the emergency room, the most common etiologies we worry about are acute coronary syndrome, aortic dissection, pulmonary embolism. In the outpatient setting, the differentials will include chest wall pain, costochondritis, gastroesophageal reflux disease, and pericarditis. So what we want to do in the office setting is basically try to find out those that are having chest pain due to acute life-threatening etiologies who would need to be referred urgently to the hospital for emergent evaluation. That initial evaluation in the office includes a history, physical examination, and an electrocardiogram. The history will include age, sex, characteristics of the pain, whether the patient has a known coronary artery disease, and what the other risk factors for coronary artery disease are. If the pain is new, if there is new onset pain or pain that is worsening in severity or frequency, it's more likely to be acute, and that should trigger emergent evaluation. EKG changes that will indicate a higher risk category include new ST wave changes, left bundle branch block, presence of Q waves or new T wave inversion. And the patients who are deemed to be high risk according to all these criteria should be sent to the emergency room for urgent evaluation. Those that are low to moderate risk could be further evaluated in the outpatient setting, probably by CT coronary angiography or by stress testing. The very low risk patients who have an obvious non-cardiac etiology for the chest pain may need no additional testing. And this next slide goes through the characteristics of the pain that would make it to be considered high probability or low probability for ischemia. So if the pain is central in location, if it's pressure-like or squeezing, if it's described as heaviness, tightness, if it's brought on by exertion or emotional stress, if it's relieved by rest or nitroglycerin, if it's retrosternal in location, those are more typical symptoms. If it's sharp, fleeting, shifting, pleuritic, positional, those are less typical symptoms. Now, we can estimate a pretest probability of the significance of the chest pain, the presence of obstructive disease, just based on the age, the sex, the type of chest pain. So older men with a typical pain have a high pretest probability based on this table. And then younger people with a less typical or non-anginal pains may have a lower test probability, a lower pretest probability. And for those with very high pretest probabilities, we could probably recommend invasive coronary angiography directly, while people with low to intermediate pretest probability need further assessment by non-invasive studies. This Marburg Heart score is utilized in the office setting to basically objectively determine risk. Is a clinical decision tool. And so for men greater than 55 or women greater than 65, 1 point is assigned. For those with known vascular disease, 1 point is assigned. If the symptoms are induced by exercise, 1 point is assigned. If the pen cannot be reproduced by palpation, then 1 point is assigned. If the patient describes the pen as being caused by heart disease, or the patient suspects a cardiac etiology, 1 point is assigned. And if you have 0 to 1 point, the likelihood of coronary disease is low, very low. If it's 2, it's 5% likelihood is low. If it's 3, it's intermediate. If it's 4 to 5, it's high. So in the office setting, those with less than 1% can probably be basically assigned to further evaluation for non-cardiac etiologies. Those that are low to intermediate probability can be worked up as an outpatient, probably by anatomic testing, which is CT coronary angiography, or functional testing, such as a stress test or stress test with imaging. And then those that have high probability probably should be referred to the hospital to be evaluated further, maybe for invasive coronary angiography. Now, this busy slide basically goes through when we think we should use a CT coronary angiogram or when we should use a stress test. The CT coronary angiogram is an anatomic test. It's essentially a CT that cuts through the heart using very tiny slices, and it's reconstructed to show the coronary arteries and whether there is obstructive plaque in them, the extent and the location of the plaque. It's very sensitive. The sensitivity in detecting significant obstructive coronary disease is up to 99% in some studies, and it's also specific, about 89%. It's becoming the preferred test of choice for diagnosis in people who are low to intermediate risk, mainly because it can detect non-obstructive plaque in addition to the severe obstructive disease. It can also detect coronary anomalies. Detection of non-obstructive plaque is associated with initiation of therapies like aspirin, statin earlier. Traditionally, we've used stress tests, and the different types of stress tests include a standard exercise treadmill test, which just requires an EKG and a treadmill. This is readily available. It is cheap. It does not require exposure to ionizing radiation. Stress echocardiograms involve obtaining echocardiography images after exercise, which could be by treadmill or pharmacologic exercise. Stress test with myocardial perfusion imaging requires utilizing radionuclide imaging. We also have a stress test with cardiovascular magnetic resonance imaging. The standard treadmill stress test is a good prognostic test because you can get information about exercise tolerance, which has a prognostic significance. However, it's not very good for diagnosis. The sensitivity is around 68%. Also, you have to have a normal EKG. It cannot be used in those who have a bundle branch block, paced rhythm, ST segment abnormalities, and it cannot be used in those who cannot exercise. For people who have non-diagnostic EKGs and who are not able to exercise, pharmacologic stress tests with nuclear imaging may be available. So what is used depends on one, local availability and local expertise, and then the patient characteristics, and we'll go over this again. Now this basically is a diagram that illustrates the flow with patients who present with stable chest pain, no known coronary artery disease. So like we've said, we do a clinical assessment, determine if they are low risk, if they are intermediate risk, if they are high risk. If they are determined to be very high risk, probably go directly to invasive coronary angiography. If it's intermediate, then we'll determine whether we will go with a CT coronary angiogram or stress testing. For some people who are older, who already have established coronary disease, in which we want to make a decision based on whether myocardium is viable, whether there is scar, and those will determine if we are going to pursue revascularization. Stress test with imaging may be more appropriate for those ones. But for those who you really want to establish a diagnosis of coronary artery disease, especially in people who are relatively younger, these days, CT coronary angiography, if it's available, is recommended as the first test of choice. So these are the recommendations for certain considerations for patients that are being seen for the first time with chest pain. So unless a non-cardiac etiology is evident, an electrocardiogram should be performed for patients seen in an office setting with stable chest pain. If an electrocardiogram is not available, then the patients should be referred to the emergency department so that an electrocardiogram can be obtained. Now, this is something we need to emphasize in the Nigerian setting where electrocardiography is probably not as widely available as it should be. And part of our challenge is to really educate the physicians about the importance of having electrocardiograms available for early assessment of chest pain. Now, patients with clinical evidence of an acute coronary syndrome or other life-threatening causes of acute chest pain seen in the office setting should then be transported urgently to the emergency department, ideally by EMS where that is available. In all patients who present with acute chest pain, regardless of the setting, an EKG should be acquired and reviewed for evidence of an ST elevation myocardial infarction within 10 minutes of arrival. And in all patients presenting to the emergency department with acute chest pain and a suspicion of acute coronary syndrome, cardiac troponins should be measured as soon as possible after presentation. So for patients with acute chest pain and suspected ACS, initially evaluated in the office setting, delayed transfer to the emergency department for measurement of troponins or other diagnostic testing should be avoided. Now, this goes through the evaluation in the emergency department, basically history, a physical examination, and an electrocardiogram. Then based on the electrocardiogram, a decision is made if there's evidence of ST elevation myocardial infarction, they go for immediate reperfusion following the STEMI guidelines. If a cardiac catheterization laboratory is available, then they need immediate coronary angiography and percutaneous coronary intervention if indicated. If a cardiac catheterization laboratory is not available, then reperfusion using thrombolytic therapy. If the EKG does not show evidence of an ST elevation myocardial infarction, then we'll follow the non-ST elevation acute coronary syndrome guidelines. They may need troponin levels, repeat EKGs, reassessment of their risk level, and then those who are determined to be high risk should go for urgent coronary angiography to evaluate for revascularization. Those that are determined to be moderate risk could go for further risk stratification based on our clinical symptoms, and they may need a CCTA or stress testing as part of that risk stratification. So this HEART score for chest pain in the ED is a clinical decision tool that is utilized for further risk assessment in the emergency room. It looks at the history, the electrocardiogram, the age, the risk factors, and the troponin, and it assigns scores of 0 to 1 to 2 for each of those for a total of 10. And if the patients have a score of 0 to 3, they are considered relatively low risk. The risk of major adverse cardiovascular events over the next 6 weeks for those with that score is 1.7%. Those ones could probably be sent home from the ED and worked up as an outpatient. Those with a heart score of 4 to 6, the risk of major adverse cardiovascular events is 16.6% over the next 6 weeks. And these patients need to be admitted for further evaluation, probably are the ones that need to undergo CT coronary angiography or stress testing to determine if they need further evaluation, if they need invasive coronary angiogram. And those with a risk score of 7 to 10, major adverse cardiovascular events over the next 6 weeks, the risk of major adverse cardiovascular events over the next 6 weeks is 50%. Those ones need urgent coronary angiography. So in addition to this, other clinical criteria such as recurrent chest pain, unremitting chest pain, dynamic EKG changes, hemodynamic instability, unstable arrhythmia, development of heart failure. These are other factors that would necessitate urgent coronary angiography. Echocardiography is indicated to evaluate left ventricular function, to assess cardiac valves, and this gives us added information that is utilized in the management of the patient. So this slide essentially summarizes the decision-making process in the emergency department. And even in the office setting, those that are asymptomatic probably need no testing. However, a category of patients such as pilots, people with high-risk occupations may be referred for further risk stratification just because of the risk their occupation poses to members of the public. Now, those that are low to intermediate risk who are symptomatic are those that would need anatomic or functional testing. The first line test today is probably CT coronary angiography when it's available. Part of this is because it's more sensitive. It can detect non-obstructive plaque. Initiation of therapy after detection of the non-obstructive plaque has been shown to be associated with a reduction in major adverse cardiovascular events compared to functional testing or stress testing. So that's what would be considered recently new guideline over the last, I'll say over the last 3 years. For people who are high risk in terms of their symptomatology, people who are high risk in terms of their presentation with an acute coronary syndrome, invasive coronary angiography where it's available is recommended. This still remains the gold standard for evaluating the coronary anatomy, establishing a diagnosis of coronary artery disease, delineating the anatomy, and then based on that, making a decision about whether the patient should be referred for revascularization. So the revascularization strategies include coronary artery bypass graft surgery. This is indicated for people with significant left main disease or triple vessel disease with reduced ejection fraction. People with single vessel disease, double vessel disease, fairly preserved ejection fraction, probably would benefit from percutaneous coronary intervention if the lesions are amenable to that. And then there are people who basically present with anatomy where the evidence suggests an equipoise between percutaneous cardiovascular therapies and coronary bypass graft surgery. And the recommendation now is that they should be evaluated by a heart team consisting of the surgeon and the cardiologist, and then the heart team should make the decision about what is best for those patients. And we'll remember that all of these patients, should be treated with guideline-directed medical therapy, including aspirin, statin, beta blockers, angiotensin blockade. Definitely coronary disease risk factor modification, including smoking cessation, should be recommended. And where available, cardiac rehabilitation should also be recommended. I will stop here for now and I'll take questions. Thank you very much for inviting me to give this presentation.
Thank you, Dr. Emerole. Thank you very much. Any questions from the audience, please? You have a question? Yes? Okay, Dr. Shangade here in Beckley, renowned general surgeon, pediatric surgeon, wants to ask you a question. So, Dr. Shangade, a couple of questions. Okay, go ahead, doctor.
There's no risk from your stratification. As a general surgeon, I've had experience where you come with chest pain and everything cardiac-wise is negative, and indeed that goblet. I just did one case just this morning. The only presentation is chest pain. We see that a lot. And in the emergency room, after they've done the cardiac workup, they send him home. They can come back with gangrenous gallbladder. Do you have that experience? Do you recommend there's no risk that you say she is sent home? She also have a gallbladder workup.
Yes. Thank you very much for that question. So when we say send home, it doesn't mean that the workup ends there. You have to look at what other disease processes could be going on based on the symptoms, and you're quite right. Gastroenterologic disease is very high up. So gallbladder, acid reflux, those are major differentials. And there are some that would have pulmonary disease, asthma, pneumonia. There are others that would have, costochondritis. And there are some that would have anxiety or panic disorders. But yes, definitely we do see people that end up having acute cholecystitis or other gallbladder problems that mimic acute coronary syndromes or even chronic coronary syndromes. Thank you.
Thank you, doctor. One more question. Maybe this may be directed to Dr. Oye, I don't know, but in rally general, do we really have CT coronary angiogram? Yes, we do. Yes, we do. Have they been doing that? Yes. Okay, thank you.
Yes. Yeah, we do have the technology here. Dr. Emerole, for our vantage point, since we're looking at improving cardiac care in rural America and Africa, what special tips would you have for our doctors in medical underserved communities on how to manage these patients? The ideal patient shows up in the office. What's that easy way for them to go through what you just said, so them to know ABC quickly?
Yeah, in the office, quick history, and then do an electrocardiogram. So if the history suggests acute chest pain, refer to the emergency room. If the EKG is abnormal, shows high risk criteria, and you have worsening chest pain, refer to the emergency room. Now, if it is stable chronic chest pain and there are no major abnormalities in the electrocardiogram, I would say today that the first test to order would be a CT coronary angiogram if it is available in your area. If it's not available, then maybe a stress test, a nuclear stress test, or refer to a cardiologist. But if it's available, I will say refer for a CT coronary angiogram if it's, it's going to give you a quicker diagnosis. Now, there are contraindications. It uses iodine-based dye. So if the person is dye allergic, they may not be a candidate. If the person has renal insufficiency, they may not be a candidate. If the person has atrial fibrillation or some arrhythmia that would prevent gating, they may not be candidates. And those are the ones that you could probably send for stress test with nuclear imaging for further risk stratification.
There's a question in the audience.
Yeah, there's a question for you, Doctor.
Yep, there's another question in the chat. Some patients coming with acute coronary syndrome require a cardiac cath procedure to determine the percentage of blockage before taking the next step. In the case of some developing countries where there is no possibility to find an interventional cardiologist, what is the alternate option?
You initiate medical therapy to the best of your ability to stabilize the patient. So if they present with an acute coronary syndrome, you start with aspirin, you start with heparin. If the EKG shows ST elevation, then, give thrombolytic therapy. Streptokinase is available in Nigeria. It's not very expensive. TPA and TNK, the other ones are available. They are more expensive and may not be readily available in an emergency. But yeah, if you don't have a cardiac catheterization laboratory, you do what you can with medical treatment to stabilize the patient and then see if you can refer the patient out after that.
Thank you.
One more final question, Doctor. In the Nigerian context, we see because of the lifestyle changes mimicking Western lifestyle, people are getting cardiac events, but STEMIs and end up dying quickly. So I know you travel quite a bit. As a cardiology group back then here, have they tried to figure out a way to ensure that these patients get early treatment if they're not readily available, if the treatment area is not readily available to them, at any regional treatment centers that you're aware of that would make it less likely to be life-threatening or long death?
Yes, we've worked with the Nigerian Cardiac Society to set up training programs for the cardiology fellows. So all of those that are basically passing through the training under the Nigerian Postgraduate Medical College or the West African College of Physicians are currently getting good exposure to current guidelines in the treatment. But you are right. Part of the problem is that the nature of the country is that many people go to different, where the access care is so different. There isn't really any standardization. And so if one is able to go to maybe a teaching hospital, they'll get something that will be considered standard of care. If they go to a private hospital that's run by a GP that graduated 50 years ago, they may not get an EKG. So we just have to continue to work to educate the public. We are working with Nigerian Cardiac Society, and probably we'll have to extend that to other medical associations, Association of Private Medical Physicians, and actually raise public awareness. Part of the problem is also economic and financial. People have to pay out of pocket for every test. And so it's easy for us to say, get an EKG, get cardiac troponin, get streptokinase, but all of this require the patient paying upfront before anything is done in most of the facilities. So that presents a problem. I think we'll continue to work on the education, educating the physicians, educating the public. We also have to work on advocacy in terms of trying to convince the people in government to finance healthcare adequately.
Thank you, Dr. Emerole. I appreciate it. We hope to see you next year in our conference. We'll also invite you and your residents, member students to join us in our global rounds, which we have every 3 months, right here in Acton, West Virginia. Our next one will be December. So if you have any interesting cases that you or your students or the president want to present, please let us know, let the group know, and we'll try to get them shown. Thank you so much. See you next year.
Thank you. Thank you. I appreciate it. Thank you. Thank you.
All right.
Thank you.
All right. Who's next? Okay. All right. Our next speaker is here to talk to us about acute coronary syndrome. Also, she's a graduate of the Woodrow Wilson High School here in Beckley, and proceeded to Wesleyan College, and then proceeded to doing a residency medical school activity in Lewisburg, WVOSM, and then proceeded to residency in internal medicine at University of Florida, and then finally currently doing completing a fellowship at the Henry Ford Medical Center in Detroit. Her name is Monique Oye, and we'll look forward to talking. Thank you.
Dr. Monique, are you there? Yep. And Dr. Emerole, if you could stop sharing your screen. Thank you. You're good to go, Dr. Monique.
All right, you can see it?
Yes, we can.
Okay. All right, so following that talk, I will be continuing it with talking about acute coronary syndrome. So a lot of that talk was the evaluation of chest pain. So then now we will go into when patients present with acute coronary syndrome, how do we manage them? How do we diagnose them? How do we manage them, risk stratify them, and the different treatment options? So to start off, we'll start off with a case, and then we will delve into the topic, and then finally finish off with how this patient was managed in their clinical course. So we had a 40-year-old female who presented to the emergency room for chest pain. Her vitals, she was a bit hypertensive with a blood pressure 151/84, heart rate 96, respiratory rate 16, and she was satting 100% on room air. Medical history was significant for tobacco use, 1 to 2 packs per day, and high cholesterol. The chest pain was central, described as heaviness radiating towards her neck and shoulders, and it was relieved with rest. No nausea, vomiting, or diaphoresis. When she went to the ER, they did do high sensitivity troponin levels, which were elevated uptrending, 650 to 774 and 824. She wasn't hypotensive, no malignant arrhythmias or refractory resting chest pain. This was the ECG when she came in, which we can see the notable findings are diffuse ST depressions with elevation and lead AVR. So this is considered a high-risk ECG for more diffuse ischemia. And a patient who presents like this, we definitely want to consider them to be high risk and do further imaging and workup. So initially she was medically managed with aspirin 325 milligrams, metoprolol 25 milligrams BID, which is a beta blocker to reduce the myocardial oxygen demand, as well as anticoagulation with heparin drip. The chest pain had resolved while she was in the ED, but she was given as-needed nitroglycerin for chest pain if she developed it. So what would you do next if you have a patient like this? And we will kind of talk about the chest pain algorithms and how to treat these patients. So when the patient comes to the hospital with chest pain, the first thing is to kind of categorize them. Are they high risk for having actual cardiac chest pain, or is the chest pain they're having something else? Is it pericarditis? Is it just demand from some other systemic process happening? Are they intermediate risk? Are they high risk? Are they low risk? So just from their story and how they present, we can kind of get an idea of where they fall. The ECG is going to be our first initial test, because if that ECG shows ST elevations, we're going to go down the STEMI protocol. There's really no further workup or testing that needs to be done. If it's a STEMI, we just need to treat because the longer you wait, the more cardiac damage you'll have. The more medical decision-making comes when there's no ST elevations. We need to decide, is this a type 1 NSTEMI, non-ST elevation MI, which is due to acute coronary occlusion, or is it type 2? They have elevated troponins, no ST elevations, but the troponins are elevated due to some other systemic process that's going on. Maybe they're septic, maybe they have an infection, but it's not due to a true coronary event. And then we have these patients who are considered unstable angina. They're coming in with chest pain. Their ECG doesn't have ST elevations. Their troponins are negative, but their presentation is still due to an acute coronary syndrome. But with the new advent of the high sensitivity troponins, we really don't see unstable angina that often anymore, because these troponin levels, which are a marker of cardiac damage, are being detected at very, very low levels. So if somebody were to come in with negative troponins, it's very unlikely that we would see this. And if we did see it, it might be just because they presented very early before the troponin had a chance to become detectable. So when we're assessing these patients, like I said, we'll categorize them as high risk, intermediately low risk. Based on the new chest pain guidelines, the way they want us to describe the chest pain is it cardiac chest pain? Is it non-cardiac chest pain? Or is it possibly cardiac chest pain? In the prior guidelines, the chest pain used to be described as typical chest pain or atypical chest pain, but they want us to get away from that nomenclature and kind of categorize it as cardiac, non-cardiac, or possibly cardiac, to reduce some confusion of saying atypical chest pain, because a lot of people don't even really know what atypical chest pain really means. And then if the patient's low likelihood, then what are the other reasons why they're coming in with chest pain? What else is going on? Is it pneumonia or something else? So we'll use our history, our exam, our ECG, and troponin levels. There's also risk scores, like we were talking about in the last talk, the heart score that can help risk stratify these patients. So the heart score, it's all going to be based on the story that the patient gives. If their story is very suspicious, central chest pain radiating up to the jaw, the left arm, worse with exertion, then it's going to be highly suspicious. Versus someone who has chest pain after working out, lifting weights, it's tender to palpation, which probably is more musculoskeletal chest pain. We'll look at the ECG if there's any changes. They're higher age, they're going to be more likely. Their risk factors and then the troponin levels. And then based on this number, they'll be either in the low risk category, which low risk patients essentially can be discharged from the ED with outpatient follow-up. And then the medium and high risk patients are going to be the ones who we want to admit to the hospital for further risk stratification and workup. So we'll get ECGs, you can repeat them every 15, 30 minutes, look to see if there's any evolving changes, because when they first came in, there might not be any major changes, but while they're there, they might start to develop more ECG changes. will trend the troponin levels. And as the troponin level elevates, the overall risk for adverse prognosis does elevate as well. So the heart score is basically to decide who can be discharged from the ED with outpatient follow-up versus who needs to be admitted to the hospital for further workup. Once the patient is decided they need to be in the hospital for further workup, we can use other risk scores to determine what's their probability of in-hospital death or their 14-day event rates. And this is just looking at their age, their risk factors, what the ECG shows, their biomarkers, to categorize them to their overall prognosis and risk. So when these patients present with non-ST elevation acute coronary syndrome, we are going to treat medically initially. So give them aspirin, anticoagulation, heparin, beta blockers, oxygen if they're hypoxic, and then put them on telemetry. The next step is deciding who needs immediate activation of the cath lab versus who can have more of a delayed approach to going to the cath lab. And this is all going to depend on how the patient looks. Are they stable or are they unstable? And remember, this is not ST elevation MI, so not STEMI or ST elevation MI. If it's a STEMI, you go down the STEMI protocol, they need to be activated, go to the cath lab immediately. So, but these patients that don't have ST elevations, but concerns for acute coronary syndrome with acute plaque rupture, deciding when they go to the cath lab is the next decision we have to make. So if they're electrically or hemodynamically unstable, or they have refractory or resistant recurrent angina, they need to get a coronary angiogram within 2 hours or less. So immediate invasive strategy. If they have elevated risk score, abnormal biomarkers, ST segment depressions, but they're not hemodynamically unstable, you can do the coronary angiogram within 24 hours. So as we know, these patients can come in at any time of the night. If they come in at 2 in the morning, this is going to be important because if they're unstable, they need to go immediately. If they're stable, the chest pain's being controlled, they're being medically managed, the interventional cardiologist doesn't necessarily need to come in exactly at that time to do it. You can wait till the morning and go to the cath lab then. And then patients that have had PCI in the past 6 months or prior CABG, CKD, diabetics, low EF, who have moderate risk score but are stable, you can do coronary angiogram within 72 hours or before hospital discharge. So next would be if the patient comes in with ST elevation MI or STEMI. So this STEMI definition is ST elevations, J point of greater than 1 millimeter and 2 contiguous leads. ST depressions with tall R waves in V1 through V3 could be a posterior MI. A new left bundle branch block could be suggestive of acute STEMI, as well as diffuse ST depressions with ST elevation and AVR. So STEMIs, all acute STEMIs warrant reperfusion unless there's an absolute contraindication to that, such as very low platelets, acute bleeding, and they wouldn't be able to tolerate the procedure without bleeding out. Or for some reason, due to their code status, they wouldn't want this procedure. Just because the patient comes in with a STEMI and their chest pain has resolved while they're there does not mean you delay reperfusion. And the system goal is less than 120 minutes of ischemic time. So then what do we do for those patients who present with STEMI, but they are not at a primary PCI center? The next option is to do thrombolysis, give them lytics to see if we can break up that clot and restore reperfusion down that vessel. So STEMI patients who present to a non-PCI capable hospital, the symptoms started within less than 12 hours. And you can, from the time they hit the door to the time you can deliver the thrombolysis is less than 30 minutes. And if transferred to a PCI capable hospital would be longer than 120 minutes or 2 hours, you can give them thrombolysis. That's class 1 indication. The different agents are tenecteplase, retiplase, and alteplase. And then as well as you give them antiplatelets, as well as anticoagulation with heparin or Lovenox to reduce reinfarction. Contraindications to lysis is mainly going to be patients who have cerebral or stroke issues that would put them at a high risk of having intracranial hemorrhage. So recent strokes, any history of prior head bleeds, known malignancies in the brain, patients who are concerned that maybe are having aortic dissection, you wouldn't want to give them lysis, severely uncontrolled hypertension, or active bleeding. So patients, primary PCI is going to be the preferred strategy for patients presenting with STEMI, who present to an experienced PCI center, and it's been less than 24 hours from their symptom onset. The goal is from the time from first medical contact to balloon time of less than 90 minutes, and from the time they hit the ED to the time they're on the cath lab table getting PCI, less than 30 minutes. So this is just from the guidelines. For primary PCI for STEMI class 1 indication, less than 12 hours from symptom onset to improve survival. What about patients who present with STEMI, and should you do CABG instead of PCI? It is class 1 indication if they're in cardiogenic shock to do PCI or CABG to improve survival. The decision to do CABG is going to be based on the anatomy that you define when you do the cardiac cath, as well as if they have any mechanical complications from their MI, such as a VSD or LV aneurysm. That could be an indication to do CABG for their reperfusion strategy. You would still do the cath, you would define the anatomy. If they're stable, take them off the table, admit them to the hospital, and have cardiothoracic surgery, evaluate them for CABG. And then in terms of patients who come in with a STEMI, but they also have other vessels that have significant occlusion, but they're more chronic and not the acute culprit vessel, it is recommended to do complete revascularization within that indexed hospitalization if they're stable. So once again, if they present to non-PCI hospitals with STEMI, the goal is going to be early reperfusion and what they call a pharmacoinvasive strategy. So you're going to give them lysis, but then you're going to transfer them to a PCI-capable hospital and hopefully be able to do angiogram with revascularization within 24 hours. The thing with giving lysis is that although you may be able to break that clot up and restore reperfusion, if you don't get the PCI, you're very high likelihood of just reoccluding that vessel. So it's not a 100% done after you give them the lysis. You still want to transfer them to hopefully get PCI if possible. So this is kind of an approach for the pharmacoinvasive approach of lysis plus PCI. If the symptoms were less than 2 hours, they have a low bleeding risk. You can give them thrombolytics, start them on anticoagulation, and transfer for elective angio. So key points, the main thing with these patients are going to be, what are the odds? What's the likelihood that they're actually having acute coronary syndrome? And to rule out any other etiologies for chest pain, like aortic dissection, because the management would be completely different. We're going to identify low-risk patients and discharge them from the ED, and we can do this by using the heart score and have them follow up outpatient for stress testing and follow up with cardiology. And then once the patient's admitted, we can further risk stratify what's their likelihood of having a major adverse cardiac event during following their hospital admission. And then we want complete revascularization. So when they come in with an acute MI, you're going to fix the culprit vessel, but before they're discharged or within the indexed hospitalization, you do want to do complete revascularization of any other significant lesions. So in terms of invasive strategy and PCI, we want that to be done within 24 hours if applicable, and immediate angiography within 2 hours if symptomatic or unstable. If the patient's unstable, you don't want to give them IV beta blockers because you could throw them into cardiogenic shock, and only give them oxygen if they're actually hypoxemic. So early reperfusion is patients presenting with STEMI is going to improve survival. Lytics are effective if the patient is not at a primary PCI hospital, but then you want to transfer them to a PCI-capable center if possible for them to do definitive PCI. And complete revascularization is going to improve outcomes. So back to our case, our patient, like the ECG showed, she had diffuse ST depressions with elevation at AVR. She was hemodynamically stable. Her chest pain had resolved while she was in the hospital. So the plan was for an early invasive strategy with coronary angiogram within 24 hours. She was managed with aspirin beta blocker and IV heparin drip in the meantime. Her cath showed that she had left main disease 71%, so that's significant. And she was referred for CABG in the setting of her isolated left main disease. She ended up getting a 2-vessel CABG Lima to LAD and a free Rima graft to OM. She had no postoperative complications and feels significantly better from the procedure. On follow-up, she did follow up in the clinic. She doesn't have any recurrent angina or heart failure or arrhythmia symptoms. And that's it. Any questions?
Thank you, Dr. Oye, for your talk. Very nice. We have a few questions here. Doctor, go ahead.
With a high suspicion of acute coronary syndrome, is there anything that would indicate adding extra leads sooner than doing the straight 12-lead EKG?
Sorry, adding extra what?
Why don't you come up? We'll come up and ask questions again.
Hi, Dr. Oye. So if we have high suspicion for acute coronary syndrome, is there any indication for adding extra leads earlier in the management? Than
Extra,
extra leads on the EKG?
Yeah, so it depends on if you think that, like if you're saying if you're concerned for a posterior MI or
yes,
right side. Yeah, depending on what your suspicion is for that, if you are concerned, then you definitely can do it. What we've seen is a lot of techs, nurses who do the ECG, they don't do it correctly in terms of adding those extra leads. They don't even know where to place them. But yeah, if you're suspicious of it, then and they're in the ED, it can be helpful because you may be able to bring out that posterior MI that you didn't see just based on the regular baseline ECG that we do.
Okay, thank you.
Any more questions? Dr. Shangada has a question for you, Monique.
Mm-hmm.
One question, and I'm kind of predicting myself. The old day we used to just say cardiac enzyme X3. What is the role of CPKMB and all the United States? Is there any role for that at all?
Yeah. So for CKMB, there's no role for that anymore. It used to be part of, the workup, but now with the new high sensitivity troponin, we're not using CKMB at all. I think at our hospital, you can't even order that lab, and it's not even part of the guidelines anymore. So it used to be useful, but now with high sensitivity troponin, they're so good at detecting myocardial damage that we're not using CKMB. Some hospitals don't have the high sensitivity troponin yet, but it's becoming more and more hospitals that do. And with the use of that, really it's useful and you don't need the CKMB.
Thank you very much. That's a very story about that's what we used to do many years ago.
Thank you very much, Monique. Appreciate it.
Thank you.
All right. No question already. Right? Okay. All right.
Thank you. You can unshare your screen whenever you're able to.
All right, we're going to move on to our next speaker. Our next speaker needs little introduction. But here recently, I will tell you, we have some new information about him that I would like to share with you all. The next speaker comes to us from Beckley, West Virginia. He's a general general surgeon and trauma surgeon, and with special interest in pediatric surgery. He's a well-established and respected surgeon in our community and nationally. He recently just got honored by the governor and state of West Virginia for being after receiving the prestigious West Virginia Governor's Award for Export in Export 2023. And the recognition reads, the esteemed recognition highlights Dr. Shangode's outstanding contributions to promote international trade in healthcare and driving economic growth through successful export initiatives. The Governor's Award for Export is presented annually to individuals who have demonstrated exceptional leadership, innovation, and success in expanding the state's export market. This is what this conference is doing too, I guess. We're trying to export the state's healthcare means, right? Dr. Shangode's commitment to excellence and his relentless pursuit of international business opportunities have significantly contributed to the state's economy and public health landscape in developing countries through strategic partnerships, market research, and a deep understanding of healthcare trends. Let's see. He is an active member of the Raleigh General Medical Society, active member of Raleigh General Hospital, and serves as the director of trauma at Raleigh General Hospital. And we're glad to have him here speak to us on a very important topic. We do know that cancer is rampant around the world, and particularly colon cancer is becoming really bad in rural and developing countries, such as Africa. So we like to have Dr. Shangode's perspective on colon cancer. Dr. Shangode, thank you.
Thank you very much, Dr. Oye, for that introduction. Just a brief information about the Export Award. We're not exporting product or anything like that, but we're exporting knowledge, very similar to what we're doing today. Dr. Oye has been very good at introducing a lot of knowledge to the rest of the world. So I focus on Central America, particularly Jamaica, Montego Bay, as one of our first area where we're trying to export knowledge. So people like you and Dr. Oye and all the pledging student that become professor and teacher, we will definitely get you involved to kind of introduce your knowledge to the rest of the world, especially the developing country. So I will say that my topic is very simple. It's a brief overview of colorectal cancer. I don't have any financial thing to disclose. I don't sell or have shares in the people that do surgical equipment, nor do I have any share in the people that sell the chemotherapy. I have to specifically tell you that I'm the vice chairman of a foundation called Uzima Foundation. I'm the vice chairman of the board of directors of that organization, which we want all of you globally to be involved. You can go to our website and review that. UZIMA is the name, uzimahealthfoundation.com. But I need to promote that. That's the only thing that I would declare that I have a big interest in. They are very supportive of this lecture series. So I'm very grateful for Cynthia, that is the chair of the board of directors. So having said that, I'm going to start with the presentation. So the whole objective of this presentation is for you all to be very conversant about colorectal cancer, okay? How to treat it, how to diagnose it early, how to prevent it, how to personally take care of yourself so you don't end up with colorectal cancer. Well, this is a picture that we're seeing. If any of you watch the Black Panther, this is one of the main actors. I'm sure you all know him, especially the young people among us. He was only 41 years old when he died of colon cancer. So this is real. And those names next to him, because this guy is a public figure, I'm able to show his picture without getting any approval from anybody. But the people next to it are not public picture. They are my close friend that died recently of colon cancer. They were young, they were very important. Dr. M.O., that's Moye, one of my closest friends, died of colon cancer. HC, Dr. Christian, a very good general surgeon in Pittsburgh, who is my close friend and associate. Dr. O, which is Olan Rewaju, that also died of colon cancer, was a gynecologist, big-time gynecologist in Pittsburgh. Dr. T.O., which one of his sons played for Steelers. He was a very important, Tony was very important, was my classmate in medical school, very big-time ENT in Pittsburgh, died of colon cancer. N.A. Ned is also my classmate in medical school. Luckily, he's still alive, but his colon cancer was diagnosed early. So these are all big-time doctors, young, that just died, it's unfortunate. And the last one was the one that just died about 2 months ago. It's a reverend. Sam is my name. Is his name. He used to live right here in Berkeley, and he moved to Seattle. So just to tell you that this is real, and it affects people like you and us. This one?
Yeah.
Okay, good. Now, let's talk a little bit about the epidemiology. It's always good to kind of know what we're talking about. So about 153,000 new cases are diagnosed annually in the US. It is one of the leading causes of cancer death globally. It's the third most commonly diagnosed cancer in males and second in females. Again, this is sex discrimination is higher in males than in females. That's a fact. The highest incidence is actually right here in North America, New Zealand, and Australia. For some reason, the lowest rate is in Africa, but I'm going to comment on that briefly. When I was in medical school in Nigeria, they used to say brain cancer was very rare in Nigeria. But that was because we didn't have neurologists or neurosurgeons at all in that country. But then when my dean that trained in Michigan came back, he was a neurosurgeon, and they started doing tests, and they find out, well, it's just almost as common brain cancer in Africa as it is here. So what I'm trying to say is that these so-called lowest rates may just be because we're not doing tests to diagnose it. Colonoscopy suit is very rare in most part of the rest of the world, and but we always assume this is probably true because of our diet and the fact that we're physically active in Africa. So this may be real, but we got to put it in mind that the diagnostic system is not as robust as we have here. Very important, this last bullet shows that the incidence is increasing in young adults. I'm going to repeat it. We are seeing a lot more colorectal cancer in young people, especially rectal cancer. Like many things in medicine, if you are practicing medicine anywhere in the world, your patient will say, why did I have this? I'm sorry, 75% of the time, your answer will be, we don't know. So you will see a patient with advanced lung cancer and say, well, I never smoked in my life. I didn't work with asbestos. Why did I have this? Your answer should be, we don't know. So why this is happening in young adults, we don't know, but this is really concerning. So maybe all related to diet, maybe all related to the sedentary that we all just stick a butt and watch TV and play games. I don't know. So, but this point is very real. I mean, you're all young and you should be very active and very, very important, very nice to know this, unfortunately. How do you diagnose this disease? Well, let's talk about symptoms and signs. There are several of us that doesn't have symptoms and yet maybe have brain cancer of the colon or rectum. But one clear thing that can happen if you start to have rectal bleeding, which in a big language, big English language, medical language, we call hematochezia. So if you're having rectal bleeding, we worry that you may have cancer. So do not worry. Most rectal bleeding is not because of cancer. It may just be ordinary hemorrhoid. It may be diverticulosis. It may just be polyp. So the fact that you're having rectal bleeding doesn't mean you have cancer, but it does require you to see your doctor. Always start with your primary care doctor and you can do workup. Okay. Now, in association with the rectal bleeding will be iron deficiency anemia. I've seen patients that see their primary care doctor and they're treating the iron deficiency anemia with iron therapy. They never do a simple rectal exam. So if you don't put your finger in it, you may put your foot in it. So please, when you start practicing, and don't just treat, oh yeah, you have anemia, so I'm just going to give you iron. Please, believe me, there's so many doctors that just do that without finding out why your hemoglobin is 7.1. This is real. So please, rectal bleeding, melena, dark stool. If your stool is as dark as my hair, you better get it checked. That's probably blood. Okay? Now, changing your bowel habits. I don't mean like just one day diarrhea when you went to Fujiyama Japanese restaurant and eat all this sushi and you have diarrhea. That's not what I'm saying. But if you have chronic diarrhea or you're constipated, and you say it's an ongoing thing, or you have diarrhea alternating with constipation, please get it checked. These are part of the symptoms and sign of colon cancer. The advanced one may give you abdominal pain because you may have an obstruction in your colon due to the size of the mass. Abdominal distension, nausea and vomiting, tenesmus, especially with rectal cancer, rectal pain with rectal cancer. And when you start to say, oh, my stool is just like pencil size, or when a patient tells you that. So narrow caliber of stool for no good reason, you gotta take it seriously. Iron deficiency, anemia, intestinal obstruction, major gastrointestinal bleeding. Some patient will come in for the first time and just say, doc, I'm bleeding out, what's going on? And then the advanced one is perforation with peritonitis, when you've had advanced cancer, you just ignore it for so long. So we don't want to do that. Before I go on, I got to really appreciate Sad and Yati for the job they did in trying to put this program together. I want you to give them a round of applause. Yati drove all the way from Toronto for this conference and she's driving back. I offered to take Sad and Yati to dinner, but they're too busy, so we'll do it another time. Toronto is one of my favorite places to vacate, so hopefully someday I will get to see Yati there. But they put this together because old man like me doesn't know how to do PowerPoint. My staff were too busy to work with me on this. So I'm grateful for Yati and Sad for putting this together at the last minute. So diagnostic study. So you've heard about symptoms and signs of what to look for. So what do we do? Colonoscopy is the big thing that we do. So the picture on your right top is a cancer that I just took care of about 6 days ago right in this hospital. So that is the colonoscopy done by Dr. Siddiqui. You see that mass is almost occupying the lumen. This guy came in, he's a 60-year-old African American that came in with very low hemoglobin and blood in the stool. So that's classic. And some abdominal pain. Obviously, this tumor is almost obstructing his left colon. That's why it's having pain. That's why it was bleeding from. We resected it. It's going home today. It was 3 of the 13 lymph nodes were positive for cancer, but we're able to totally resect it with free margins. Now, the sensitivity of colonoscopy is about 94.7%. There's something called CT colonography, which we don't do too much here, but colonoscopy is what we do frequently. We have excellent gastroenterologists here that does that, and some of the surgeon does the colonoscopy. I used to do a lot of this, but I'm too busy doing real surgery that I don't do this anymore. So I depend on the gastroenterologist to help me make this diagnosis. Flexible sigmoidoscopy. In the olden day, we used to do sigmoidoscopy as a diagnostic study, this is not useful anymore. You need to do full colonoscopy. There's something called CEA, carcinoembryonic antigen, which is a tumor marker. Many cancer has markers that you can just do and see, but the sensitivity is only 46%. Because if you're a heavy smoker, this CEA will be high, or if you have diverticulitis or inflammatory bowel disease. So it is useful to do it as a baseline, and it's also useful to follow it up to see the effect of your treatment. Now, there's something called fecal immunochemical test for occult blood that also is useful. And then when you watch your TV, you see a lot of advertisement for Cologuard. This is basically testing your stool and some chain DNA that are shared from the cells of the cancer. Now, barium enema is an old-fashioned test that you can do if for some reason you couldn't do colonoscopy, and also in the developing world or the area where you don't have enough people to do colonoscopy, barium enema may be useful. This probably didn't show too much on the screen, but the picture you write down is a classic apple core lesion. You remember when you get your apple and you're eating it, you don't eat the central part of it, and you end up with a core. So that narrow part is the cancer compressing the lumen. So this is very classic. So the classic thing that you see on barium enema is apple core lesion. Now, risk factors. Why do some people have it? I need to really emphasize the influence of race. This is a disease that discriminates quite a bit. The African American, the Black Americans has a higher incidence of this cancer. And their cancer is detected very late, very advanced, and at a younger age. So all these people that I first mentioned were all African American. They were young. The Black Panther guy was only 41 years old. So this is real. So Black Americans, Native Americans, Alaskan natives, they have the highest incidence and at a younger age. The role of diet and lifestyle. I love my steak, so I enjoy my red meat. I don't eat too many processed meat like bacon or something like that, but I do like my steak. So I'm at a high risk of having this disease because of my red meat. So please slow down on your red meat. There's a lot of other issues related to too much steak. This is a fact. Booze, when you drink too much alcohol, I do maybe, at my age, I'm not supposed to do more than 3 drinks a week, but I think I do 4 drinks a week, mainly wine. So this is a fact. Luckily, I do not smoke cigarettes. Obesity, the last time Dr. Oye commented on my weight, he said I'm not too fat. But I consider myself a little bit obese. At a height of 5'11", I weigh 206. My ideal weight should be 195. So I'm only 11 pounds off, so which I'm trying to shed, and it's difficult. So to be serious, red meat, processed meat, alcohol, tobacco, and obesity. This is real. So please slow down on that. Now, there are other things called inflammatory bowel disease, ulcerative colitis. In the olden days, if you have ulcerative colitis for 10 years, we will recommend doing a total colectomy because your risk of cancer in your colon is very high. Recently, it has been shown that Crohn's disease is in the same stage. Previous radiation, for some reason, due to pelvic cancer, can increase your risk. Cystic fibrosis, yes. Now, there's a lot of genetics. The younger generation are into genetics big time, which is great. So there are 2 syndromes that I will emphasize: Lynch syndrome and then familial adenomatous polyposis. That increase your risk of cancer for some reason. So this is real. And then how do we prevent colon cancer? And this is difficult to tell you, but just like everything, including cardiac and coronary disease, peripheral artery, you got to increase your physical activity. Don't be couch potato like Shangode. When I get home, I'm always so tired because I get home usually around 9 p.m. from 6 a.m. to 9 p.m. nearly every day. I don't want to do anything. I just want to sit on my couch and watch some TV. So I think I'm active because of my surgical system. But all of us should increase our physical activity, exercise, be active, that reduce your chance. Now, everybody's been saying this for a long time. Luckily, this is coming into being among the younger population. High fiber fruits and vegetable diet. When I first came to this country in '74, the idea that I'm eating salad was so adverse to me. I call it good food. And then I remember one of my roommate in medical school, his dad was a big time millionaire in Nigeria. We were on the plane together going to Europe, and they served him the salad and fruits and said, "This is for good. Get this out of my movie." So what I'm trying to say is that nowadays everybody's into eating fruits and vegetables and high fiber diet. This does help. So this may be actually the reason why we think the rate of colon cancer is low in Africa, because we eat fresh fruit, very little processed food, high fiber fruits. Unfortunately, many of these countries are becoming too westernized, and the Western disease will start to creep in, just like you've heard that from Dr. Oye most of the time. We used to think we don't have pulmonary emboli. We used to think we don't have MR. We used to think we don't have peripheral vascular disease. Now all this is coming up because we eat Western diet. Now, surprising to me, aspirin and non-steroidal anti-inflammatory disease can reduce the risk of colonic adenoma and colon cancer by up to 30%. I used to take aspirin every day, and then one day I started to have a melena stool, and I talked to my cardiologist, said, "What's going on?" So he said, "Stop taking the aspirin every day, take it once a week instead." So because of this, I refuse to totally stop my aspirin. But you all know that in people above the age of 60 or 65, I believe, NSAID has increased risk of GI bleed. So, but for younger people, aspirin, we're not talking about full dose aspirin. Baby aspirin is just as good. Definitely does reduce the risk of colon cancer. This is real. There are a bunch of studies that say this could be up to 40% reduction. So please increase your physical activity. If you don't learn anything from this lecture, learn about prevention. Increase your physical activity, high fiber, fruits and vegetable diet, less red meat, no alcohol. I know the kids like to drink beer, but that's okay, just once in a while. So that's the brief summary of prevention. So I want to just talk to you about treatment. The pictures on your right, the one that I did about 10 days ago, you will see a tumor inside the lumen. That's the one I showed you the colonoscopy. 3 of the 13 lymph nodes that I resected were positive for lymph node, for cancer, for metastatic cancer. The margins, you have to be worried about the margins of your resection to be free of cancer. According to the pathology, this is free of cancer. So this patient was 60 years old that came in with very low hemoglobin. So the main treatment of colon cancer is surgery. If you can resect it, if it's locally, just localized. So the main treatment is still cancer. Chemotherapy, the chemotherapy people will use the 5-FU, the oncologist, and oxaliplatin as part of their treatment. But they kind of decide on which one to treat. If you're lymph node negative and all the tumor is resected, you probably do not need any chemotherapy. This patient with 3 lymph nodes is kind of one of those, maybe we should treat, maybe we should not. This patient has not had any metastasis, so it is good. He went home today, did very well. We resected the left colon, and we are able to anastomosis. Radiation treatment is mainly for the rectal cancer, not so much for regular colon cancer. But this is the kind of treatment which is mainly surgical. Now, this histopathology that I'm showing you was another young man that came in August 29 and had hemoglobin of 7.1 because he's been having dark stool for many weeks before coming in. Hemoglobin was 7.1. Dr. Melux, our gastroenterologist here, did the colonoscopy and found a big tumor in the splenic flexure. So I wasn't the original surgeon on this case, but the surgeon that went in to find cancer that is locally advanced and has spread to the spleen, to the pancreas, and the main tumor was in the splenic flexure. So they have to do major resection, resect portion of the colon, distal pancreas, and spleen. Luckily or unluckily, this patient bled 1 hour after surgery and had to be taken back to control the bleeding. I got in on this case the second day because patient bled massively again and we almost lost him. But I was able to stop the bleeding by going back in and re-exploring. Patient went home about a week ago, but he was here for a long time. So the majority of cancer of the colon are adenocarcinoma arising from the mucosa. But other tumor that you can have in the colon include lymphoma, GIST, Kaposi sarcoma, and metastasis from different part of the body. Now, staging. There are several ways to stage this, but the most popular one is TMN. Basically, T stands for the size of the tumor, M if there's metastasis. Like in a patient that we did about a week ago, there's no distal metastasis. N stands for node. So if you don't have metastasis to the node, it would be NO. If you have 0 to 3 lymph node, 1 to 3 lymph node positive, it would be N2. So this patient is N2. Tumor was about 4 centimeters, so it was T2. So TMN classification is what we need to know, but this is what is preferred by the American Joint Committee on Cancer. Now, clinical staging is very straightforward. You do good physical exam, which you all should know how to do. Do CT scan and so on and so forth. The role of PET scan. You don't do PET scan as a diagnostic tool, but it's like a follow-up. After, if you think the patient has cancer that has really metastasis, you want to see where it is, and PET scan is very useful for that. So there are a role for all these modality that are definite, but TMN staging is, so PET scan is also for staging depending on how bad you think it is. Now, prognosis. I used to call, when I was in residency, I used to call oncologists people that just bury people. I mean, I used to really make fun of them because nearly every one of their patients dies soon. But they've improved their treatment so well that nowadays for cancer of the colon, 65% survive 5 years in US. In the other part of the world, this mortality rate is not as good. That's because they don't have all these pharmaceutical treatment modality or diagnostic studies. So even though you see this 65% survive 5 years, do not be deceived. In Black American, in Native American, the survival rate is very, very poor and bad, okay? So we are lucky we live in US and the survival rate is not as bad as the rest of the world. Now, what is the future? There's so many things developing in cancer generally. There is a multi-cancer detection test that is being developed, and young people like the student in this room will be getting involved with this to find out how you can do one blood test and say, oh, in about 2 years, you're going to have ovarian cancer, you're going to have colon cancer. This is in active development. There's microRNAs, methylating, circulating DNA markers that are all being developed. These are not state of art yet, but it's going to be there. So do you have any questions, everybody? Again, I have to thank Yati for doing a good job putting this together. Any questions, Doctor? Yeah. Dr. Singh, any questions? Thank you. Anybody has any questions? You mean you know it all? That's not true.
Thank you, Dr. Sengade, for that excellent presentation. I would like to mention that as of now, for our diagnostic screening, and colonoscopy is the only screening method that we have that can detect precancerous lesions. So if you think about mammograms, we're looking for early stage breast cancer or CT chest for those who have a history of lung cancer, smoking, and we're looking for lung cancers that are there. But with colonoscopies, when you guys are doing those, we can detect the precancerous polyps before they come colon cancer. So everyone should get their colonoscopies and make sure you're telling your family member that all of those lifestyle modifications that you mentioned are extremely important, because as of now, 40% of all cancers can be contributed to diet and lifestyle. So making those positive lifestyle changes and staying up with your colonoscopies. And for younger people, if you have symptoms that are not right, make sure that you're going to your doctor. And even if you say, I'm 35 years old, I'm too young for colon cancer, as we know from what you said, nobody is too young at this point.
Okay, just to kind of follow up on what she just said, is very important. I mean, the guideline is that at age 40 or 45, you should have your first colonoscopy. It used to be 50. They reduced that to 45. Me personally, Dr. Bu Abu does my colonoscopy, and I do have polyps, and he takes those polyps out so they don't develop into cancer. And I'm supposed to go to him every 5 years. Because I'm Black, I may have to go to him frequently, but I have to find a reason why I'm going to, because he may not want to do it less than 5 years, because my insurance may not pay for it. But if he does a colonoscopy and doesn't find any polyp, the guideline is to wait 10 years. But be careful, that 10-year thing is going to change. But if you have any family history of cancer, or you have something suspicious, do not follow the guideline of say wait for 10 years. For Black American, that age is being reduced to 35, just so we can catch it early. If we catch this thing early, it is treatable and possibly curable. Thank you very much.
There's two more questions
go ahead.
from the virtual audience. So one question, how long does it take for pathology to get back?
In our hospital, 3 days. But in some area, maybe 1 day, I don't know. Dr. Singh, do you have a comment on how quickly? 3 days in this hospital, other part of the world, I don't know.
And one more question, what determines whether to have surgery or not?
Okay, well, surgery is, I mean, if you have a patient that is showing metastasis in the liver, you did chest X-ray, and there's metastasis everywhere, you did CT scan, there's metastasis in the liver, then you have to, and patient is not having obstructive symptom, you have to really sit down and talk to the family and the patient. Do you want us to do surgery? Because then surgery will be very palliative. But if you de novo have cancer that is resectable, surgery is still the best way to go. So, but that's a judgment question, just like a decision, just like in medicine. 40% or 50% of what we do is a form of art, it's not total science. So it depends on everybody, but surgery is still number one thing. But if you have a sick patient, a DNR, or somebody that whose lifestyle is very poor or doesn't really plan to live for more than 1 year or 6 months, you may just do palliative. But most of the time you can resect and do a palliative resection to prevent bleeding or obstruction.
Two more questions. So next question, for patients with a family history of colon cancer, at what age would you recommend they start taking baby aspirin?
Good question. I think baby aspirin should be started like about 20, 25 years of age.
And last question, how common is upper GI bleed in colon cancer? I know we normally see lower GI bleed.
Well, the upper GI bleed is not common in colon cancer, but if you have obstruction and everything is back up, then your stomach lining will be congested and you have moderate bleeding, but not a major bleed.
That's all.
Thank you.
That's one more question for you.
Talking about preventative care, basically. So I read on about the Zima Foundation, which is your foundation, right? So I just read that you have programs in Africa. So talk about preventative care. Do we have workshops, events, meetings where we inform the people of the rural Nigeria or Africa, about the prevalence and the need to actually go or
Yes. So one of the things Oyesis Foundation or Zima Foundation is doing is education. I mean, Zima Foundation started in Gambia. That's just our test country right now. So we're probably going back in January. Zima Foundation people, about 11 of us went just this April, this year, April. And one of the things we want to do is to educate the people about how to prevent colon cancer. Yes.
Thank you, Doctor.
Thank you, Dr. Sangade. I appreciate it. Okay. Okay. Thank you very much, everybody, for staying through the course. It's been an exciting 2 days of intensive lectures and mind intriguing discussions. I hope you have found them fascinating. Part of the process of this, goal of this whole process is to improve healthcare one way or another, and also endovascular care particularly. We want to advance endovascular care in rural America and Africa and other medically underserved communities. The Endovascular Conference for Africa and Rural America, under the auspices of AMA PRACategory Surgical Society, was to continue the legacy Dr. Dietrich left us upon his departure from this planet in February of 2017. As I stated at my opening statement, Dr. Dietrich was very influential in the world of endovascular surgery and cardiovascular surgery. He was our mentor, and we learned a lot from him, and we're here today because he was such a fascinating figure and a great teacher. We will continue to press on Dr. Dietrich's vision to ensure that his vision goes to all corners of the world. We would also like to say that the last year's conference, AMA-PRACategory conference, Global Endovascular Conference for Africa and Rural America, is also on the YouTube channel. This year's conference will also be on that channel at some point, and ground rounds also will be on that channel. So if you go on Dr. Oye YouTube channel, you should be able to hopefully find some of those information. I'd like to particularly thank our coordinators, as Dr. Sangade had mentioned, for the effort, time they put in trying to bring this conference to a successful completion. Dr. Yati Gupta, I can say not enough. She drove all the way from Canada and will be driving back right after this conference. She's been instrumental in reaching out to all our doctors from around the globe to ensure that they were able to help us during the conference. So Dr. Gupta, thank you so much. Appreciate you. Saad Akhtar also has been very involved in the making of the brochure and also the commentaries and reaching out some of the doctors also. Other participating young doctors include Dr. Abu Aruna and also Krista, who presented, Marcos, who presented earlier in the course yesterday. Would like to say thank you to you all. Again, the goal of our conference is to spur that communal educational collaboration between physicians, hospitals globally to ensure that we're able to treat patients. And when we find something unique in our clinical practices, we're able to share those information with our peers. So again, thank you for joining us. And I'll be remiss if I don't thank our host institution this year. Was Raleigh General Hospital, Mr. David Bunch, the administrator, and his the CEO and his administrative team, who have been very gracious to help us out for the conference. Last year, we had the Duchess International Hospital in Lagos, and next year's conference remains to be seen. Other contributors I must give credit to include the Zuma Foundation, which is doing great work and trying to expand healthcare disparity issues in Africa and other parts of the world. The AMA Vascular Society, you heard our president, Dr. Don Olson, give a speech today on dissecting thoracic aneurysm management, and the International Society of Endovascular Specialists Africa chapter, which I'm the president. Again, thank you to all our speakers from around the globe. It was a pleasure having you over the past 2 days, and we hope to see you again on future conferences, and look forward to seeing you all participate out. We encourage our medical students and residents to participate because it's a platform for you to get prepared, get knowledgeable, and also become well known. It's one way for you to be known and maybe good for your CVs in the future. Thank you very much, and thank you, and good night.
Thank you so much. Thanks, Yadi.
Thank you.
Thank you, Melissa.